Yeah, good afternoon. Good afternoon.
Good afternoon, Mosi ma'am. Congratulations.
Thank you so much, Dr. Pradhan.
Thank
Thank you.
you.
The next speaker is Shabnam only.
Yeah.
Yes.
Yes.
All the best. All the best.
Thank you, ma'am. Thank you very much.
And we will wait till up to 201.
We'll wait
Yeah.
for another minute or so.
Good afternoon to all. Welcome to the afternoon session. We have another 3 more lectures to go. One on endocrine disorder, next on the government policies, and third on the cleft lip and palate. So we welcome you all to this program once again. So our first topic is on medically compromised patients, endocrine disorder by Dr. Shabnam Sahe, ma'am. We welcome you, ma'am.
Thank you, sir.
The moderators of the session is Dr. Dhanuji and Dr. Devapriya Pradhan.
Thank you,
Dr.
sir.
Dhanuji is a professor at Subbaiah Institute of Dental Science, Karnataka, with an extensive academic and clinical experience in pediatric dentistry. Completed BDS and MDS from STM Dental College, Dhawat. Currently a PhD scholar and recognized guide under Rajiv Gandhi University. Held the leadership role in IDA, ISPPD, including the president of ISPPD and vice president at state and national levels. Published around 27 papers, holds multiple patents, received research grants, and recognized among the top dental professionals with national awards. Experienced academician, researcher, and innovative speaker with significant contribution to the pediatric dentistry, public health awareness, and dental education initiative. We welcome you, sir.
Thank you. Thanks a lot.
Dr. Devapriya Pradhan, a pediatric dentist with over 20 years of extensive clinical and academic and teaching experience, has completed BDS from SCB Medical College, Cuttack, and MDS from TGIMH, Chandigarh, building a strong academic foundation. Currently serving as a Vice Dean at Kritikarni Dental College, Jabalpur, and EC member of ISPPD 2026. His expertise includes pediatric endodontics, early childhood management, orthodontics, sedation dentistry, and treatment of special needs children. He has numerous national and international publication, presentation, textbooks, contribution, and active involvement in research and conferences and academic activities. We welcome you, sir.
Thank you, sir.
Then, sir, kindly introduce our speaker.
Dr. Shabnam Zahir is, first of all, she's a very close friend of mine, and I take a privilege to introduce her. Dr. Professor Shabnam Zahir is a professor and head of the Department of Guru Nanak Institute of Dental Sciences, Kolkata, with extensive academic experience. Completed BDS MDS from R. Ahmed Dental College, Calcutta, and PhD from Dental Sciences, PhD in Dental Sciences in West Bengal University. Serves as a clinical director, Special Smile, Special Olympic Bharat, West Bengal, focusing on oral healthcare for children with special needs. Experienced consultant pediatric dentist at reputed hospitals and Smile Design multi-speciality dental clinic with successful clinical practice. Recipient of multiple awards including JIS Samman, Lifetime Achievement Award, and Distinguished Woman Award for excellence in dentistry and academics. Former executive committee member of ISPPD, actively contribute to the professional organization and advancement of pediatric dentistry in India. She has more than 100 publications, delivered numerous presentations, and actively promotes awareness and oral healthcare besides being a trained classical singer. Here I introduce Dr. Shabnam Zahir.
Thank you, sir. Thank you very much for such wonderful words.
Good afternoon, everybody. Before starting my presentation, I would like to thank our President, Dr. Balika Sir, ISPPD Secretary General, Dr. Virendra Goyal Sir, Chief Coordinator of the program, Dr. Moshini Goswami Ma'am, Co-Coordinator, Dr. Anant Raj, and all the participants. I'm very honored that I have been given an opportunity to speak in this wonderful platform. So this is the sixth time that I will be speaking for the certificate course of special healthcare needs in dentistry organized by Indian Society of Periodontics and Preventive Dentistry. The topic of my today's presentation is medically compromised patients, endocrine disorder. And I myself is Dr. Professor Shabnam Zahir, and I'm also a clinical director of Special Smile, Special Olympic Bharat, West Bengal. So I have distributed the topic in 5 subheadings. The first one is diabetes mellitus with dental manifestation and treatment in children. Second one, adrenal disorder with dental manifestation and treatment in children. Third one, parathyroid hormone disorders and their dental manifestation and management in children. Fourth one, growth hormone disorders in children and their dental manifestation and management. And the fifth one is thyroid disorders in children and their dental manifestation and management. First, I will be talking about diabetes mellitus in children and their dental manifestations and dental management. Diabetes mellitus is a group of metabolic diseases in which there are high blood sugar levels over a prolonged period of time. Diabetes is either due to the pancreas not producing enough insulin or the cells of the body not responding properly to the insulin produced. There are 5 types of diabetes. That is type 1 diabetes. Also, it's an autoimmune disorder and it requires an insulin therapy. Type 2 diabetes, where there is insulin resistance and it is mostly lifestyle related. Gestational diabetes, which develops during pregnancy and it resolves after childbirth. That is monogenic diabetes in the rare genetic form. It also includes MODY, that is maturity onset diabetes of the young. And there is a type 5 diabetes which is recently discovered and it is also known as malnutrition related diabetes mellitus, and it mostly occurs in children and adolescents in poor country because of long-term undernutrition. In normal condition, the pancreas produces insulin and by beta cells of the pancreas. Whereas in type 1 diabetes, the beta cells of pancreas fail to produce insulin and the cells does not get the glucose. Whereas in type 2 diabetes, the beta cells of the pancreas produce insulin, but cells do not accept the insulin. So type 1 diabetes is characterized by an immune-mediated destruction of insulin-producing pancreatic beta cells, leading to absolute insulin insufficiency. This form previously referred to as insulin-dependent diabetes mellitus or juvenile diabetes. The symptoms of type 1 diabetes in adults, children, and adolescents are excessive thirst, excessive hunger, unexplained weight loss, blurred vision, slow healing of cuts and sores, fatigue, vaginal yeast infection, frequent urination. Type 1 diabetes, the causes are either because of different infections like enterovirus, coxsackie virus, rotavirus, or cytomegalovirus. It may be because of autoantibodies working against beta cell antigens and development of type 1 diabetes. Genetic may be linked to the development of type 1 diabetes. Coming to the pathophysiology of type 1 diabetes mellitus. So in type 1 diabetes, basically the T cells destroy the beta cells of the pancreas, resulting in to no insulin received, and it's an autoimmune disorder. Now, type 1 diabetes is the most common form in the children, and its prevalence is gradually increasing worldwide, and it is associated with systemic and oral health complications. The global incidence of type 1 diabetes mellitus worldwide, there are 227,000 new childhood cases worldwide, and the incidence is increasing 2 to 3% every year. The highest incidence reported in Finland and Sweden, and lowest incidence in parts of Asia and South America. The incidence of type 1 diabetes in India is 95,000 children estimated to have type 1 diabetes in India, about 15,000 to 16,000 new cases annually. And the prevalence varies between the region, and India has the highest number of childhood diabetes cases. And the clinical features already I have discussed. There is polyuria, polydipsia, polyphagia, weight loss, fatigue, and risk of diabetic ketoacidosis. And the dental health of diabetes mellitus includes there is increased incidence of dental caries, halitosis, increased incidence of gingivitis, which leads to periodontitis, tongue abnormalities, xerostomia, altered taste, oral infection, and impaired hearing. In type 1 diabetes mellitus, it begins with insulin resistance, then fail to respond to the insulin properly. Previously, it was referred to as non-insulin dependent diabetes mellitus or adult onset diabetes. And the primary cause is excessive body weight or sedentary lifestyle. In type 2 diabetes, it is still relatively uncommon in children when compared to type 1 diabetes. This prevalence is sharply increasing worldwide in India among children because of their obesity and lifestyle changes. In 2021 estimates in India, it was found out that 397 adolescents among 1 lakh adolescents have type 2 diabetes mellitus, and boys has more prevalence 12% and girls 8.4%. Global burden of diabetes mellitus was found out that between 1990 to 2021, incidence of diabetes in children and adolescents has risen to 94%. So mortality because of diabetes has reduced, but there is a rising health threat. Now, how type 2 diabetes mellitus affects the body? Like diabetes mellitus 1, there is confused thinking, dry mouth, more slow to heal, burning or tingling in hands or feet, irritability, they feel hungry, fatigue, unintentional weight loss, urinating excessively, inflamed or red gums, feeling very thirsty. Etiology is genetics and lifestyle. Now, type 2 diabetes may have a very strong genetic profile. It has been found out if one of the homozygotic twin has type 2 diabetes mellitus, there is a 90% likelihood the other will also develop it. And in the family history, it was found out that most pediatric patients have at least one parent with the disease. And over 50 polymorphisms are linked to type 2 diabetes mellitus. And the second cause of type 2 diabetes mellitus is the lifestyle and the environment factor. Obesity is a primary driving factor for insulin resistance in children. Also, high intake of processed energy-dense diets like sugar and fats increase the incidences of type 2 diabetes mellitus among children. Physical inactivity, as it reduces the muscle's ability to utilize glucose efficiently, so it causes type 2 diabetes mellitus. Now, the oral manifestations are aggressive periodontal diseases, altered taste sensation, also known as dysgeusia, because of reduced saliva and high glucose levels. And there is increased risk of oral infections like oral candidiasis, and there is delayed healing of any oral infections. In type 2 diabetes mellitus in children, they show excessive alveolar bone loss with the periodontal pocket. And it has been also found out that the glucose level in gingival trabecular fluid of the children with diabetes mellitus provides a buffering environment that favors the growth of subgingival anaerobic bacteria. Other oral manifestation of children with diabetes, type 2 diabetes mellitus are xerostomia and salivary dysfunction. There is also, because of hypofunction of reduced salivary flow, leads to a cobblestone appearance of the tongue, as you can see in the picture. Also, they cause sialoadenosis. And the sialoadenosis is basically a chronic, non-inflammatory, painless condition characterized by the diffuse, painless, soft enlargement of the salivary gland, typically the parotid gland. Other form of diabetes are maturity onset diabetes of the young or MODY, and this is not autoimmune, it is purely genetic, and it is because of the defect in the beta cell function. It is mostly diagnosed in adolescents below the year of 25 years. It is an autosomal dominant inheritance, and initially it is non-insulin dependent. Other type of diabetes are gestational diabetes, which is first recognized during pregnancy. Basically, placental hormones like progesterone, cortisol create insulin resistance to ensure the fetus get enough glucose. If the mother's pancreas cannot compensate, gestational diabetes may later develop. There is a genetic link associated with GDM, and while GDM resolves after birth, but these mothers and their children have high risk of developing type 2 diabetes in later of the life. Other specific type of diabetes are type 3C or exocrine pancreatic diabetes, which is caused by physical damage to the pancreas from cystic fibrosis, chronic pancreatitis, or trauma. Drug-induced diabetes, often caused by long-term use of corticosteroids, which are common in treating asthma or autoimmune disease in children. Another type of diabetes is monogenic neonatal diabetes, which occurs in the first 6 months of life, a single gene defect rather than an autoimmune attack. Now, the major complication of diabetes, these are microvascular complication. Microvascular, they may affect the eye, kidney, the nerves, brain, heart, and extremities. Now, the typical symptoms that lead to diagnosis of type 1 diabetes mellitus in children are polyuria, polydipsia, weight loss, constant hunger. Many a time, we dental surgeon can help in diagnosis of type 1 or type 2 diabetes in children if they shows severe gum bleeding, severe inflammation of gum, bone loss. Then we can advise them for evaluation of blood for blood glucose level. The American Diabetes Association established diagnostic criteria for diabetes mellitus. If the elevated fasting plasma glucose level is 126 milligram per dl or more, that means the child has diabetes mellitus. And if the elevated our plasma glucose level above 200 milligram per dl during conducting an oral glucose tolerance test with 75 milligram glucose. And if the HbA1c test, if it is more than 6.5%, then also it is indicated the child might have diabetes mellitus. When there is a random blood sugar test, and if it is more than, blood sugar is more than 200 milligram dl, which is also indicative of diabetes mellitus. In some patients, Auto-antibody testings are done, and this auto-antibody testing basically detects GAD antibodies and distinguishes between type 1 and type 2 diabetes. Also, there is a test for C-peptide level. If there is no level of C-peptide, then there is body is not producing enough amount of insulin. Also, there is test for ketones. If there is increased sign of ketones in urine, there is a sign of diabetic ketoacidosis. According to WHO definition of gestational diabetes, is fasting blood sugar of more than 126 milligram per dl or a 2-hour level of 140 milligram per dl. Oral glucose tolerance tests are also done to determine the body's ability to metabolize sugar. So, if the fasting people without diabetes, they have fasting value under 6 millimole per liter, whereas people with impaired glucose tolerance test, they will have before test it is 6 to 7 millimole per liter. At 2 hours, it is 7.9 to 11 millimole per liter. So these are the dental complications like mouth dryness, children with diabetes mellitus, oral acetone smells in poorly controlled patients, brittle teeth, dental caries, recurrent oral infections, mouth ulcerations, altered taste sensations, periodontitis, gingivitis, etc. Coming to the pathophysiology of dental complications of diabetes mellitus. Now, diabetic-related microangiopathy results in a considerable decline of blood flow to the teeth and dental structures that leads to ischemic toothache and tenderness of gums, bone erosions, and even teeth loss. Polymorphic dysfunction is another pathophysiological mechanism involved in dental poor health among diabetes that facilitates recurrent oral infection. Hyperglycemia also impairs protein metabolism, enhances collagen breakdown, and eventually delay healing. There is a study by Pauling that oral health of children and adolescents with diabetes mellitus, where they found out that children with diabetes mellitus exhibits higher incidence of dental caries. But that may be because of more frequent intake of meal, because of higher sugar concentration in saliva and lower saliva flow rate. And also in the children with diabetes, because when they have poorly controlled diabetes, this leads to drop in the pH value and reduction in the cleansing function of saliva, which may again cause increased incidence of dental caries. So, in case of controlled and uncontrolled diabetes mellitus, salivary flow rate decreases, which may have a risk of developing caries in children with diabetes mellitus. There is another study by Sotria et al., oral health implication and dental management of diabetic children, that they found out there is certain changes in the saliva of children with diabetes mellitus. It shows that the salivary flow, their buffering capacity is reduced and irrespective of their metabolic control, which causes them increased incidence of dental caries. Moreira et al. Reported there is significant reduction in salivary flow rate in children with diabetes mellitus. Oseni et al. Reported that there is hyperglycemia glycosuria, which reduces the rate of salivary flow. Some studies shows the buffering capacity or the pH also lowers in children with diabetes mellitus. Then the salivary viscosity also increases in children with diabetes mellitus. The immunoglobulin like IgA level, IgG antibodies are found to be higher, whereas the levels of antimicrobial proteins like lactoferrin lysosomes are lower in the saliva of children with diabetes mellitus. Moreira reported that salivary calcium levels are higher among children with diabetes mellitus. Now, children with diabetes mellitus often reported with dry mouth because decreased production of saliva, and this can be corrected by advising them to drink plenty of water. Older children can use sugar-free chewing gum to increase the saliva flow. Vaselins can help protect the dry lips and soft tissue. Dry mouth gel applied on the tongue and around the inside of the cheeks can also help lubricate the mouth. This can be prescribed by our doctor or a dentist. Over-the-counter saliva substitute or mouth spray can provide temporary relief from dry mouth. And routine dental check enables early detection of complications of dry mouth. Now coming to the growth and development in children with diabetes mellitus. Children diagnosed with diabetes were taller than non-diabetic children at the onset of the disease. Nevertheless, the annual growth velocity decreases after diagnosis, reaching a lower than normal final height. Sexual maturation is delayed both in girls and boys. Menarche occurs at a mean age of 15 years in girls, and full sexual maturation occurs in boys, which occurs at 17 years, which are much increased than in normal, where in menarche in girls occur average 13 years, and in sexual maturity occurs in non-diabetic boy at 15 years. It's very important to take the psychological care of children with diabetes mellitus because stress-related mental disorders, anxiety disorder, depression, and eating disorders emerge more often in children and adolescents with type 1 diabetes than in healthy people. Now, effect of dentition and eruption in children with diabetes. In early mixed dentition, most studies observe an accelerated eruption of permanent teeth, whereas in late mixed dentition, many studies report a delay in the eruption process of children with diabetes mellitus, and these have consequences. Because of this altered eruption sequence, it can lead to crowding and malalignment. Poor alignment makes hygiene difficult, often increasing the risk of gingivitis and periodontitis. It may necessitate early orthodontic intervention. Dental management protocol in children with diabetes mellitus. Very important are prevention and maintenance. Home care should include 2 to 3 daily brushing with fluoridated toothpaste. 2 to 6 years, we can use 1000 ppm of fluoride. Ages above 6, 1450 ppm fluoride can be used. But in India, only 1000 ppm of fluorides are used. In-office care includes fluoride application, topical fluoride applications like varnishes application 3 to 4 times per year for high-risk patients. Those who have periodontal disease or gingivitis, antiseptic solutions can be given them to rinse their mouth after the age of 6 years. Before 6 years, ointments of chlorhexidine can also be given, or chlorhexidine sprays can be advised. Now, the chair-side precautions include always morning appointments are preferred to reduce stress and where there is natural cortisol levels are high. And always we should verify the child has taken his meal and taken their insulin before starting. Stress reduction, use self-show technique to prevent stress-induced hyperglycemia. Re-examination and professional training should be advised after every 3 to 4 months, which normally in healthy children we do after every 6 months. Management of non-controlled patients. Patients who have poor metabolic control, we have to postpone any electric treatments. Only emergency work has to be done, like a very severe painful condition. Antibiotic prophylaxis, if you have to do, we can go for an extraction. But additional hemostatic measures to counter immunosuppression and delayed healing should be achieved. Emergency protocol if there is hypoglycemia. Hypoglycemia means when the blood glucose level is less than 70 milligram per day. Treatment varies depending upon the patient conscious level. If the patient is conscious, step 1, administer 15 gram of fast-acting carbohydrate. Step 2, replace glucose in 15 minutes. If still low, repeat carbohydrate. Once it is more than 60 to 70 milligram per day, provide a sugary beverage like orange juice or sugar water. But category B means when the patient is unconscious because of hypoglycemia, immediate call for emergency medical service, inform the treating physician, and if IV access is available, 5 to 25 gram of 50% dextrose can be given through intravenous route. And if no IV access is available, glucagon 1 milligram intramuscularly or subcutaneously can be given, or glucosate applied to the oral mucosa. Now, are these diabetic child patients suitable for orthodontic treatment? So there is this article by Ahmed Al-Mahdi who mentioned that things should be considered that we can safely go for orthodontic treatment in children with diabetes mellitus, but few considerations before starting an orthodontic treatment that the child should have good oral hygiene. There should be good control of the diabetes mellitus. There shouldn't be any periodontitis. We should monitor the blood glucose before starting any orthodontic treatment. During the process of orthodontic treatment, we should advise to apply light physiological forces. Antibiotic prophylaxis are indicated before orthodontic band placement, separator placement, or screw insertion. But antibiotic prophylaxis is not needed when there is simple adjustment of appliances or simply replacement of appliances. Consideration to prevent or manage emergency during the process. Excuse me. Morning meal on the day of orthodontic treatment, the child should not miss. He should have a normal insulin. If symptoms of hypoglycemia occur, IV dextrose or iron glucagon should be given. Now, is there any link between obstructive sleep apnea in children and diabetes mellitus? So there is, I found the studies by Crystal, and there is another study by Pritha Rajan, obstructive sleep apnea risk factor for type 2 diabetes mellitus, where we found out that there is a high prevalence of insulin resistant and type 2 diabetes mellitus in patients with obstructive sleep apnea. And they have even higher prevalence of obstructive sleep apnea has been documented in patients who have type 2 diabetes mellitus and who are obese. Now, the sleep fragmentation, activation of sympathetic nervous system, and the chronic intermittent hypoxia secondary to recurrent apneas in obstructive sleep apnea may contribute to abnormal glucose and insulin metabolism. So this chronic intermittent hypoxia contribute to hepatic and peripheral insulin resistance as well as to pancreatic beta cell disinfection, independent of the obesity. That's why it's very important screening for obstructive sleep apnea in the population with type 2 diabetes mellitus. Now, can we go for sedation in children with diabetes mellitus? It is crucial to use local anesthesia with caution, preferring solution with low adrenaline concentration to minimize any risk. This is especially in patients who have inadequate glycemic control. The use of conscious sedation is preferred in children with diabetes mellitus over deep sedation to ensure the child's comfort and safety during the next. The insulin regimen should be adjusted by the endocrinologist before any dental intervention. Prophylactic antibiotics may be recommended before surgical procedure and vasoconstrictor drugs with local anesthesia to ensure proper anesthesia are advocated. But excessive adrenal dosage should be avoided to prevent increase in the blood glucose level. Now, diabetic ketoacidosis, this is a life-threatening metabolic crisis. It occurs because of hyperglycemia, ketonuria, and electrolyte imbalance, leading to metabolic acidosis. The clinical presentation, how you will understand, there will be a throaty smelling or acetone break. Patient will complain of lethargy, vomiting, and there may be a potential coma. Prevalence is 15 to 70%. To manage it requires immediate hospitalization, and there should be intravenous fluid should be given, IV insulin, and potassium monitoring should be given. Now, in diabetic ketoacidosis, the investigations that we do, that blood glucose and ketones, vitals should be checked for pH and bicarbonate for acidosis, chest X-ray to rule out any infections, infection screening for full blood count and culture. ECG should be done to monitor the electrolyte-induced arrhythmias. So, for management of diabetic ketoacidosis, basically you refer to an hospital. There they will administer intravenous fluids, check the serum potassium level, administer either short-acting or regular insulin. So, this is in short how you will be doing the dental management protocol for diabetic children. The conclusion, childhood diabetes is increasing worldwide. Oral complications are common, but pediatric dentists have very important role in early detection and management of dental complication of diabetes mellitus, and preventive care significantly improves oral health outcomes in children with diabetes mellitus. Now, coming to the second endocrinal disorder, that is adrenal disorder, its dental manifestation and treatment in children. Adrenal glands are small endocrine glands located bilaterally at the superior pole of each kidney. They are important glands that regulate how human body responds to stress, and their deficiency or hypersecretion can lead to undesirable effects. Now, coming to the functions of the hormones produced by the adrenal glands, they secrete steroid hormones like glucocorticoids, which regulate the metabolism, help in stress response, anti-inflammatory. They produce aldosterone, which maintains sodium and water balance, regulate blood pressure, control the potassium level. Also, they produce adrenal androgens, which contribute to growth and development, role in secondary sexual characteristics, influence puberty, and support growth and metabolism and electrolyte balance. Now, the different type of adrenal disorders are congenital adrenal hyperplasia. It has a direct oral manifestation. Children, they show advanced dental age. The permanent teeth erupt significantly earlier than their peers. And they also show enamel hypoplasia and amelogenesis imperfecta, which may be due to the systemic insult of fluctuating hormone levels or the long-term use of replacement corticosteroids affecting the enamel matrix mineralization. Now, the different diagnostic tests that can be performed to determine the adrenal disorders are plasma catecholamine levels in the blood determination. Serum cortisol level can be determined. If it is low, that is adrenal insufficiency. If it is high, that is Cushing's syndrome. If the adrenocorticotropic hormone levels are determined, if it is high, that is primary adrenal insufficiency or Addison's disease. If it is low, then it is secondary adrenal insufficiency. And there is a goal test for determining the adrenal disorders are ACTH stimulation test, and synthetic ACTH is given and cortisol measured before and after injection. If there is failure of cortisol drive, there is adrenal insufficiency. Dexamethasone suppression tests are also done to determine the suspected Cushing's syndrome. Dexamethasone given at night, cortisol measured next morning. If there is failure of suppression, that means there is hypercortisolism. Now, various imagings are all determined to determine the adrenal disorder, like to determine adrenal enlargement. Ultrasound abdomen can be done. CT scan, MRI are done to determine the detailed view of the adrenal glands to detect whether there is any adrenal tumor, hyperplasia, or atrophy. The various adrenal disorders are adrenal insufficiency or Addison's disease, congenital adrenal hyperplasia, Cushing's syndrome where there is increased cortisol, and secondary adrenal insufficiency. Now, increased cortisol disorder usually referred to as Cushing syndrome. Now, the Cushing syndrome is mostly caused by pituitary tumor, most common, or adrenal tumor. And the Cushing syndrome is characterized by excessive secretion of glucocorticoids by the adrenal glands. And the symptoms are weight gain, broad round face or moon face, buffalo hump on the upper back, abdominal stripe, hypertension, hirsutism, acne, etc. And other symptoms may include diabetes mellitus, heart failure, etc. Now, the oral manifestation of Cushing syndromes are there is immunosuppression, so there is more oral candidiasis, recurrent herpes labialis, herpes zoster infection, gingival periodontal disease, and impaired wound healing. Now, coming to primary adrenal insufficiency, where there is damage or dysfunction to the adrenal cortex, resulting in deficient production and release of cortisol, aldosterone, and DHA. It mostly causes is DHA. Causes are autoimmune disease, infections like tuberculosis, HIV, metastatic bleeding, or medications like ketoconazole. Now, Addison's disease is caused by lack of secretion of cortisol and aldosterone from the adrenal cortex, which lead to impaired metabolism, glucose, fat, and protein, as well as hypotension, impaired fluid expression, excessive pigmentation, and inability to tolerate stress. Now, coming to secondary adrenal insufficiency, where there is damage to in the primary adrenal insufficiency, there is damage to the adrenal gland, but here there is damage to the pituitary gland, which stop chronic, resulting in deficient ACTH, cortisol, DHA. And the causes are pituitary tumor, infection like tuberculosis, autoimmune, pituitary trauma. Exogenous corticosteroid uses can also cause secondary adrenal insufficiency. Now, secondary adrenal insufficiency is mostly symptomless unless patient is significantly under stress and does not have adequate circulating cortisol during stress. Now, the treatment, acute adrenal insufficiency, where there is acute adrenal crisis, that is replace cortisone with IV hydrocortisone, replace aldosterone with IV fluids, correct hypoglycemia, and correct electrolytes. Whereas in chronic adrenal insufficiency, replace cortisol with glucocorticoids, replace aldosterone with fludrocortisone, and replace androgen with DHEA. In chronic adrenal insufficiency, replace cortisol, replace androgens, and aldosterone, you have to remind that not effective in secondary. Now, if adrenal insufficiency remains undiagnosed and untreated, it should result in a condition called adrenal crisis. It may develop within hours and it may be characterized by sunken eyes, profuse sweating, hypotension, weak pulse, cyanosis, nausea, vomiting, weakness, headache, dehydration, fever, dyspnea, myalgia, or arthalgia. Now, treatment includes IV hydrocortisone, depend by the dose, depends on the age, fluid replacement, and referral to medical care. Basically, whenever these type of emergency occurs, you have to refer the patient to the hospital. And because if they are not treated, they may lead to hypothermia, severe hypotension, confusion, circulatory collapse can also result in the death. The dental manifestations of the adrenal disorder are oral mucosal pigmentation, which is very common in Addison's disease, delayed wound healing, increased infections, osteoporosis of the jaws, periodontal disease susceptibility. Because of the prolonged use of steroid, there are oral candidiasis, there is risk of adrenal crisis during dental stress. Now, adrenal disease and the dental management. Dental treatment can act as a stress trigger and leading to adrenal crisis. So early oral signs like pigmentation in Addison's disease may help in early diagnosis. We can refer the patient to the endocrinologist to confirm diagnosis of any adrenal disorder. Now, children on long-term steroid therapy require a special precaution. Excessive epinephrine in local anesthetic must be avoided in patients with increased adrenaline levels in blood. Need for steroid supplemental before major dental procedures is advised, and a multidisciplinary approach of management is very much important. Now, before the dental procedure, the blood pressure should be checked. Blood glucose levels should also be checked before any dental procedure. Aspirin, non-steroidal anti-inflammatories should be avoided for patients on long-term corticosteroid therapy because these patients may suffer from peptic ulcer and non-steroidal anti-inflammatory drug could aggravate these conditions. So, in primary adrenal insufficiency, when you do any dental procedures like routine dentistry, no supplement is required. Whereas a secondary adrenal insufficiency, also no supplement required. But when we do a minor surgical procedure, in primary adrenal insufficiency, we give 25 milligram of hydrocortisone preoperatively on the day of procedure. Whereas in secondary adrenal insufficiency, the daily therapeutic dose can be given. Whereas moderate surgical stress, major surgical stress, though as pedodontists we don't do, but the maxillofacial surgeons may be doing, and these are the, you can go through this doses that you can follow. Now, the precautions to be taken before doing a dental procedure, blood flow should be reduced because it increases the probability of hypotension. Morning appointment, stress-free dentistry should be encouraged. Undiagnosed, untreated adrenal insufficiency should be referred for medical care before starting any dental procedure, and dental procedure should be postponed. Long-acting local anesthetic should be used to minimize pain and post-operative stress. Supine position of the patient with adrenal insufficiency to reduce hypotension. Some drugs like ketoconazole should be discontinued by the patient 24 hours before the dental surgery, with the patients be consulting with the patient physician because this may lead to adrenal crisis. Role of pediatric dentist, there should be early detection. But through oral pigmentation, we can suspect the presence of Addison's disease and send them to the endocrinologist. We should prevent any dental infections by regular maintenance and preventive therapies. Free dental care should be done. We should be ready for any emergency, and the multidisciplinary approach is very important. So this is the clinical protocol that always medical consultation before any dental procedures are very important. Anxiety management, pain control very important. Always schedule a morning appointment. And emergency protocol, if there is adrenal crisis, shock treatment, patient in supine position, oxygen can be given, hydrocortisone, you can give IM or IV, call emergency, shift to the hospital. There is one case report of Addisonian hypopigmentation as oral manifestation, which is published by Priyanka et al., where they describe a 10-year-old boy who reported to the Department of Pediatric Preventive Dentistry with generalized hyperpigmentation of the skin and within the oral cavity. And laboratory investigation, they reveal significant changes of ACTH levels and cortisol levels, and they diagnosed with Addison's disease of these children. And as the child was indicated for a dental procedure, it was done under local anesthesia with adrenaline. A pre-medication of hydrocortisone with double the dose of normal was prescribed 1 day prior and continued for next 2 to 3 days as per pediatric endocrinologist's opinion. This is another patient with Cassie syndrome, which was reported by Sandeep Quikel, where the child, 15-month child, gave a history of moon face and increased this obesity. And the mother gave a history of excessive weight gain of the child. And the mother was breastfeeding the child, at the same time consumed prednisolone 5 milligram once daily for the treatment as a maintenance dose of IgA nephropathy. And the mother was also applying over-the-counter topical steroid, clobetasol, and that may be the reason which has causes Cushing syndrome in the child. And early recognition is very important, and any dental procedure should focus on stress reduction, prevention of infection, careful treatment channels, and multidisciplinary approach while doing a dental treatment is very important. So, third topic that I will be discussing are parathyroid hormone disorder and their dental manifestations and management in pediatric patients. Now, basically, this endocrinal disorders that I will be talking is hypoparathyroidism and hyperparathyroidism. Now, in hypoparathyroidism, there is low blood parathyroid hormone, which causes hypocalcemia, decrease in blood calcium, and hyperphosphatemia, where there is increase in the blood phosphate level. This is a very uncommon condition, that is hypoparathyroidism, where there is insufficient secretion of parathyroid hormone, and etiology is congenital, genetic, autoimmune cause, or iatrogenic causes after thyroidectomy or neck surgery, or accidental removal or damage to the parathyroid gland. Hypoparathyroid assessment is done by sophastic signs, by Trouse's signs. In sophastic signs, the facial muscle twitching elicited by tapping the facial nerve anterior to the ear, suggesting hypocalcemia, and Trouse's signs, carpal spasm produced by inflating a blood pressure cuff above systolic pressure for 3 to 5 minutes, indicating latent hypocalcemia. Now, the dental manifestation of hypoparathyroidism are enamel hypoplasia, delayed eruption, short roots, hypodontia, and paresthesia. And the dental management of hypoparathyroidism includes monitoring calcium and vitamin D regularly and maintain appropriate calcium and vitamin D level. Fluoride varnish application regularly to prevent any dental caries. Preventive dental care should include good oral hygiene maintenance, recommend a calcium-rich diet, frequent dental cleaning. Hypocalcemia symptoms can be managed by understanding the signs of hypocalcemia like tetany, paresthesia, muscle cramp, oral numbness, etc. Special considerations for the dental procedures are short or traumatic appointments, which we can consider sedative or nitrous oxide. We can minimize the use of local anesthetics. Ongoing dental monitoring are very important after every 3 to 6 months. After every 3 to 6 months, check jawbone development. Now, the sign and symptoms, if we compare hyperparathyroidism with hypoparathyroidism, In hyperparathyroidism, there is renal calcification, whereas in hypoparathyroidism, there is hypocalcemia. In hyperparathyroidism, there is bone pain, whereas in hypoparathyroidism, there is tetany. In hyperparathyroidism, there is psychosis, depression, mood changes, whereas in hypoparathyroidism, there is epilepsy. Now coming to hyperparathyroidism. In hyperparathyroidism, there is increased production of hypoparathyroid. It can be primary, secondary, and tertiary. Primary causes because of adenoma, secondary because of chronic hypocalcemia and trisomia. Tertiary is because of autonomous disease, and it is because of chronic kidney disorder. It occurs by the increase in calcium. And the dental manifestation in hyperparathyroidism are loss of lamina dura, brain tumors of jaw, delayed eruption, malocclusion, jawbone demineralization. And the dental management of hyperparathyroidism before treatment, medical consultation is very important with their endocrinologist or the physician. We should check their serum calcium and parathyroid level. We should take an OPG to see whether there is any bony change of the jaw or not. During dental care, while doing extraction, we have to be very careful because there is bone is fragile. Otherwise, there is fracture of the bone. We should avoid any traumatic procedure. Local anesthesia should be given carefully. We should treat the periodontal disease early, manage the mobility of the teeth, monitor brown tumors of the jaw, and maintain a very strict oral hygiene. Regular follow-ups should be done with a regular radiographic evaluation, hearing assessment after extraction, and we should regularly coordinate with the child's endocrinologist. Now coming to the fourth endocrinal disorders, that is growth hormone disorder in children and their dental manifestation and management. Now, the growth hormones secreted by the anterior pituitary, and it is controlled by the hypothalamus. Growth hormones are essential for craniofacial development. And because of dental maturation and eruption are highly sensitive to growth hormone level, the dentist is often the first clinician to detect the pituitary dysfunction. Now, growth hormone has a very important role in endochondral ossification and intramembranous ossification. These growth hormone disorders are classified into two types, that is growth hormone deficiency or pituitary dwarfism, and growth hormone excess or pituitary gigantism. Growth hormone deficiency, the causes are congenital, maybe because of pituitary aplasia or hypoplasia, maybe because of some genetic mutations, because of craniopharyngioma, like this type of tumors, maybe because of trauma or infection of pituitary tract, or maybe idiopathy. Then hypopituitarism or pituitary dwarfism, it's basically because of deficiency in growth hormone, which causes marked reduction in the growth and development. The craniofacial morphogenesis, which causes changes. There is macrognathia, both maxilla and mandible are smaller, and because they are smaller, there are crowding of the teeth, and the skull and the facial skeleton show disproportionately delayed growth, resulting in a face that appears much younger than the chronological age. And in the soft tissue, there is fine wrinkle that may appear around the mouth and the eyes. The general clinical features include short stature, delayed puberty, delayed skeletal age, increased adiposity, and the child appears younger than chronology. The dental sequelae of growth hormone deficiency are there is delayed eruption of the permanent tooth. There is even the shedding of the decidual teeth are delayed. The tooth, there is morphological anomalies of the tooth, microdontia, short clinical crowns are very common in pituitary dwarfism. The roots are even shorter, which retarded growth, and they are many times associated with amylogenesis imperfecta enamel hypoplasia, and high prevalence of third molar agenesis in case of pituitary dwarfism. In the radiological finding will find there is delayed dental age that we can determine through the OPG, delayed root development, reduced mandibular length, and the hand twist radiograph will show delayed skeletal age. So, dental, in case of growth hormone disorder, we should assess the biological age not the chronological range. Periodic radiographic evaluation is very important. Preventive care like fluoride application, sealant application should be done. We should monitor the eruption sequence, early orthodontic referral advice. We should coordinate with the pediatric endocrinology before starting any dental treatment and monitor the patients on the recombinant growth hormone therapy. Now coming to the second type of growth hormone disorder, hyperpituitarism 1 or gigantism. Excess growth hormone secretion occur here before the fusion of the epiphyseal plates in childhood, and the craniofacial alteration includes symmetrical overgrowth, where generalized enlargement of all body parts, including the facial bones. Mandibular prognathism, there is accelerated growth of the mandible, leading to a class 3 skeletal profile. Radiographic markers like intraoral radiograph frequently reveal hypersymmetries of the tooth root. And in case of there is acromegaly, there is progressive somatic disfigurement appearing in adulthood. There is soft tissue hypertrophy like macroglossia, enlarged tongue, facial feature, there is thickened negroid lips. There is a massive lantern mandible prognathism or lantern jaw in acromegaly, and because of increased size of the mandible, there is increased spacing or diastema of the tooth. Taurodontism are also common here. And the radiographic features of here are enlarged mandible, increased lower facial height, enlarged maxillary sinus, advanced dental development. Now, the clinical management includes a multidisciplinary approach, like dental must use panoramic to compare with the chronologic age with the biologic age, and orthodontic management should be done in hypopituitarism to relieve crowding, whereas in hyperpituitarism, class 3 malocclusion should be corrected. And we should always be careful about systemic problems like sleep apnea from macroglossia, and we require a multidisciplinary approach. Role of pediatric dentist: early identification of growth abnormalities, timely referral, growth modification planning, long-term follow-up. So in hyperpituitarism, there is delayed eruption, whereas in acromegaly, there is proportional accelerated eruption. In case of hypopituitarism, there is crowding, whereas in hyperpituitarism, there is spacing or diastema. Hypopituitarism, there is retarded mandibles, and hyperpituitarism, there is a prognathid or lantern jaw. In case of hyperpituitarism, small or retarded tooth, whereas in hyperpituitarism, there is hypercementosis. Soft tissue, there is fine wrinkles in case of hypopituitarism, whereas macroglossia, thick lips in case of hyperpituitarism. In conclusion, growth hormone disorders significantly affect the craniofacial growth. Multidisciplinary management is essential, and pediatric days are very crucial role. Coming to the last endocrinal disorder, that is the thyroid disorder in children and their dental manifestation and management. Normal thyroid gland function is critical for early neurocognitive development as well as for growth and development throughout childhood and adolescence. Among various endocrine disorders, thyroid gland disorder is one of the second most commonest endocrinal disorder in children. In India, 1 out of 2,640 neonates suffer from thyroid disorder. Now, diagnosis of thyroid disorder mostly by physical examination, by the signs of like delayed accelerated reduction of teeth, by blood tests determining the thyroid stimulating hormone or T3, T4. Imaging, ultrasound, CT scan may be used to visualize the thyroid gland, their size and structure, and we can refer them to endocrinologist for confirmation. So in the lab result, what in hypothyroidism, there is thyroid stimulating hormone is increased, whereas free T4 is high in hyperthyroidism, but it is low in hypothyroidism, whereas free T3 is high in hyperthyroidism, whereas low in hypothyroidism. Classification of the thyroid disorder: hypothyroidism, which can be congenital or acquired; hyperthyroidism, like Graves' disease, and others are thyroiditis and nodules. Hypothyroidism, the clinical features are short stature, delayed milestone, puffy face, dry skin, bradycardia, and intellectual disability. So these are the symptoms. Many are like hair loss, sports faces, weight gain, cold intolerance, delayed puberty, heavy menses. These are found in the hypothyroidism. Recently, one child came to our clinic with a history of hypothyroidism at the age of 9 years. I asked the mother, how did you find out that the child has hypothyroidism? The mother told the child has got severe menses at the age of 9 years, so their physician advised a blood evaluation where they found out that the T3 and T4 production is reduced in them, whereas TSH production is increased. So this is a girl where they have hypothyroidism caused by Hashimoto's disease, and before the treatment, and you can see after the treatment how the facial feature has changed. Now the oral findings of hypothyroidism are delayed eruption, macroglossia, thick lips, enamel hypoplasia, and malocclusion. So this is a child with hypothyroidism showing macroglossia, and anterior open white is found in congenital hypothyroidism. So they have a direct influence on development, and I'm not going in so much details because already I'm ahead of time. So I'm going in short. So in hyperthyroidism, there is weight loss, heat intolerance, tachycardia, and exophthalmos. And other hypothyroidism symptoms are protruding eyes, enlarged thyroid gland, excessive sweating, short attention span, etc. And the oral findings of hyperthyroidism are early eruption, increased caries risk, periodontal disease, burning mouth. This is a picture of an 8-year-old child suffering from hyperthyroidism, where 8-year child, even though you can see the second prominent molar has also erupted. Now, the comparison between hypo and hyperthyroidism. In hypothyroidism, there is delayed eruption. Hyperthyroidism, there is early eruption. In hypothyroidism, there is macroglossia, whereas in hyperthyroidism, there is burning mouth. In hypothyroidism, there is slow metabolism. Hyperthyroidism, there is hypermetabolism. This is a study by Venkatesh Babu, oral health status of children suffering from thyroid disorder, where they found out that children who have thyroid disorder have high incidence of dental caries and periodontitis, and that the children without any thyroid disorder and children with thyroid disorder also exhibited microglossia, open bite, and change in eruption pattern. In general, the dental management includes taking a detailed medical history, consultation with their physician, pediatrician, or endocrinologist, stress reduction during any dental procedure, vital sign monitoring before, during, and after the dental procedure are very important. In hypothyroid child, avoid CNS depressants. Short appointments are advisable, monitor healing, and there is risk of myxedema coma in them that is actually cautious. In hyperthyroid child, avoid epinephrine if uncontrolled. Anxiety control is very important. Monitor the pulse and BP before, during, and after procedure. Postpone elective treatment if the thyroid level is unstable. Thyroid storm is a dental emergency which is indicated by high fever, severe tachycardia, confusion, and the needed hospital referral is included. The various preventive protocols that are indicated in children with thyroid disorders are fluoride application, diet counseling, regular recall, and oral hygiene reinforcement. So there are various drugs that can be given for endocrine systems for diabetes mellitus, thyroid disorder, adrenal disorder. I'm not going into details, but these drugs many a time given in the form of syrup because of the frequent exposures can also cause increased in the caries because these syrups have got sugar. Now, in conclusion, early diagnosis saves complications, and pediatric dentist plays diagnostic role, and interdisciplinary care are very much important. So these are the references, and this is my email ID. If you have any questions, you can mail me. And lastly, I would like to thank you for your patience hearing, and thank you for organizing such a wonderful program for 6 consecutive years. Thank you very much.
Thank you, Dr. Shabnam Zaid.
Thank you, sir. Thank you very much.
Any
I
questions?
think there is one question in the chat box.
Yes. We have 2, ma'am, and one more question.
There is one question in the chat box.
What is the
Just
rationale using?
what is the rationale for using local anesthetic without vasoconstrictor in patient with diabetes mellitus? Many a time, basically using vasoconstrictor, we can use vasoconstrictor with local anesthetic in children with diabetes mellitus, but many a time we prefer using local anesthetic without vasoconstrictor to reduce the incidence of epinephrine-induced hyperglycemia in these type of children. Am I all right for the answer?
Yeah, perfect.
There is another now questions. Basically, there is another question.
In what situations are long-acting local anesthetic indicates for patients with type 2 diabetes, and why?
That is because we want to, because when you use local anesthetic long acting, so post-operative pain will be delayed, and so stress-induced hyperglycemia will be less in these patients.
Yes. One more is there. Could you suggest any over-the-counter saliva substitutes?
There is, I think ICPA has got one over-the-counter saliva substitute. That is, I just forgot the name. It's there is an ICPA. They have this one. I will get back to you. I don't remember now the name. I forgot it. So, Hina? Huh? Saliva. Okay. Dr. Shridhar has helped me in giving the answer. So I think you got the answer.
One more question is there.
Chronic dental abscess in a PAD child, that desirable their long-term glycemic control and HbA1c. Can chronic dental abscess in PAD child?
I think this chronic dental abscess is certain. There are studies where they are telling that if there is a type 1 diabetes mellitus and there is a chronic dental abscess for a long time and there is a stress associated with that, and it may cause hyperglycemia and it may aggravate the condition.
Can you throw more light on malnutrition induced DM? Diabetes mellitus.
This malnutrition-induced diabetes mellitus basically is a very newly discovered or identified diabetes mellitus, and it is mostly occur in country where there is severe malnutrition, and so it is mostly it's very new one, and in our country though it is very less. So for long time when they are not getting their food, and that may cause this type 5 of malnutrition induced diabetes mellitus.
Dr. Pradhan, any questions?
No, sir. Fantastic. This excellent.
Very good presentation, as usual.
Yeah.
I thank Dr. Secretary General Dr. Virendra Goyal, Dr. Moshmi Madam, and my dear Anand Raj for giving me opportunity to moderate. And very nice presentation, Dr. Shabnam Zahir. And thanks,
Thank
Pradhan.
you very much, sir. Thank you very much.
Thanks a lot.
And we have the certificate for Shabnam ma'am.
Thank you, everyone.
Kindly accept the certificate, ma'am.
Thank you very much. Thank you very much for giving me an opportunity to speak. Thank you very much.
For the moderators, please. Thank you, Dennis, sir.
Thanks,
sparing your time.
Thanks a lot.
And thank you, Divya Pradhan, sir.
Thank you so much, sir.
Thank you, sir.
Nice to have you. Thank you.
So we'll move on to next session, that is special healthcare needs, government policies and schemes.
Devika?
by Dr. Ashik Saxena, and this session will be moderated by Dr. Lakna Gowda ma'am and Dr. Bhumika Devi ma'am. Dr. Vairakovam Bhumika Devi is an associate professor and head pediatric and preventive dentistry, Regional Institute of Medical Science, Imphal, with 13 years of teaching experience. She completed her BDS from SDM College, Dharwad, and MDS from KD Dental College, Mathura. She had led the department to multiple ISPPD awards through community outreach, dental camps, and public dental health aware initiatives. She has published in national and international journals, delivering guest lectures and chaired scientific sessions and led funded research projects. An active member of IDA, ISPPD, and RIMS Medical Society, she received the Women of Substance Award in 2025. We welcome you, ma'am.
Thank you so much, sir, Dr. Anandara, sir. And thank you for inviting me as a moderator. I would like to say good afternoon to Mosmi ma'am also, and Virender Goyal, sir, and my co-moderator Langra Goda ma'am, and Asis Saxena, sir, also. Mosmi ma'am, good afternoon.
Good afternoon, and very nice to see you all over here.
Thank you, ma'am. Baliga, sir, also.
Okay.
Good afternoon.
Dr. Lagna Gowda is an associate professor at M.R. Ambedkar Dental College, Bangalore, with over 15 years of academic experience. She has completed BDS and MDS in pediatric dentistry from VS Dental College, Bangalore, serves as an academic council member at Rajiv Gandhi University of Health Sciences and executive member of ISPPD, holds distinction in child psychology, Montessori training, and certification in systematic review and meta-analysis from Johns Hopkins University. Actively involved in international research collaboration on brain entertainment technique to reduce the anxiety in children. We welcome you, ma'am.
Thank you.
Very nice to see your CV, Dr. Lagna. Very interesting CV.
Thank you so much, ma'am.
Welcome.
Ma'am, kindly introduce our sister.
And welcome. Looking forward to a great session.
Lagna ma'am, kindly introduce.
Good afternoon, sir, and good afternoon, all the participants. I would like to introduce our esteemed speaker of today's specific course and certificate course on spatial healthcare needs in dentistry. I would like to introduce our sir, Dr. Asis Saxena, who has completed BDS from Government College of Dentistry, Indore, and MDS from King George Medical College, Lucknow. He is currently serving as professor and head of Department of Periodontics and Preventive Dentistry at Government College of Dentistry, Indore, Madhya Pradesh. He has over 15 years of teaching experience as both clinician and academician, and contributes significantly to dental health education and training programs, actively involved as researcher and administrator, and have developed effective care strategies for undergraduate, postgraduate students, and dental technicians in pediatric dentistry. Sir has also expertise which includes pediatric dentistry, preventive dentistry, and management of children with special healthcare needs requiring specialized dental treatment approaches. He has also skills in sedation dentistry, aesthetics and cosmetic dentistry, general dentistry, and management of medically compromised patients with complex dental conditions. He also has a strong knowledge in dental aesthetics and prejudice, ensuring professional standards and ethical practice in clinical, academic, and research environment. Sir, we welcome you on behalf of the organizing committee. Thank you, sir.
Thank you so much, Dr. Bhumika and Dr. Gowda. Thank you so much, ISPPD also.
Hello?
Volume is not there.
Apparently volume is not there.
They are helpful to deliver good kind of treatment for them.
Can you start from the beginning?
Good afternoon to the respected moderators and the people who have registered for this course. My topic of presentation is special healthcare need, government policies and schemes. So as a pediatric dentist, we want to know about the policies and the schemes which are very much helpful to the people of differently abled. And why we want to know about the government policies and the schemes? Because they are helpful to deliver good kind of treatment for them. And it is a part of the basic fundamental health right that every citizen should have the general health as well as the oral health. So there is a department of the government which is known as the Ministry of Social Justice and Empowerment, that is under the central government, and they have launched one program which is known as Accessible India Campaign, also known as the Sugamya Bharat Abhiyan, and it was launched on the International Day for the people of with disabilities, that is on 3rd December, and the same day has been celebrated as a Pediatric Dentist Day in our country. So let us understand about the difference between policy and the schemes. Both are part of the government, but a policy means a set of ideas or a plan what to do in a particular situation that has been agreed to officially by a government or a political party. So policy is basically a kind of plan which is decided by government or a political party, while a scheme means a design or a program and action to be followed. So it is basically a part of the policy regarding the implementation. We have two departments that have been created under the Ministry of Social Justice and Empowerment. One is the Department of Social Justice and Empowerment, which is known as the Samajik Nyaya and Adhikarita Vibhag. The other one, which is of our interest, that is known as Department of Disability Affairs. And it is renamed as Department of Empowerment of Persons with Disability. So these are the two departments, and for our interest, that is known as DEPWD. Why there is a need of such kind of departments? So we have to understand that these people who are differently abled, or we call them as a special healthcare need people, they are individuals and they need some recognition. They need a place to live of their own choice. They have rights and they have right to participate in the decisions which are affecting their life. The excess of the amount of support it takes to enable everyday living, which includes adequate health, and it has been discussed and passed in the Mental Health Foundation 1996. Why we are trying to know about the different kind of policies? Because we want to help the families, we want to help the people, those who are handling them, and we want to entertain them in a good way. So we should understand about the different kind of government schemes. If you discuss about the families, so there is happiness, there is a bundle of joy that new person is coming into their family, and after some time when they realize that the child is not as per the norms what the society has fixed, or as per the growth, the child is not reaching to the milestones which a child should reach, so the family, they become little bit disheartened. It is kind of shattering of their dreams. It affects a lot of their individual relations. It affects their family relations, and it is a kind of personal trauma, because these people, it takes a lot of time to adjust with the child problem. Such people are difficult to connect with the societies. Such people, generally, they do not continue their profession. They leave their ambitions to go further in their life, and such kind of sacrifice a family has to take care. So as a dentist, we have to help them. We have to understand the problem of the family, of the child, and how they are taking care of the child. As we all know that our branch is pediatric dentistry, and as per the definition, whatever is the definition, that ends with including those with special healthcare needs. So it is part of our branch, it is part of our duty that being a pediodontist, we have to treat these children who are having the special healthcare needs. And for treating such children, we have a designated branch that is known as special care dentistry, which is basically for the improvement of oral health for the special healthcare children or the differently differently abled children. If we are going for the prevalence of the special healthcare need, so it was started in 1872 when we have started census in our country during the British period, and from that time, the counting, the census of the population started for the disabled people also. And from 1872, it has continued till 1931, stopped for some time, and after 50 years, that is 1981, it is again started. So recent data what we have, that is from the 2011, and as per the index, we have 2.21% population, that is around 2.68 crores people in our country which are having some kind of disability. This is 14 years old data if we are going for the latest data which is there into the social media, but not as per the census. And almost 4.52% people of our whole population, they are affected by any kind of disability. And if we are counting as per the population, that is almost 6.32 crores out of 140 crore plus population. During the journey of the various act which has been passed for the supporting or in favor of the differently abled people, so it has started like legal provisions of on disability in India. First was Mental Health Act, which was 1987, followed by the Rehabilitation Council of India, which is made in 1992, and Act in 1995 has been passed, that is for persons with disabilities, giving them equal opportunities, protection of rights, and full participation. Then the National Trust for the Welfare of Persons with Autism, Cerebral Palsy, Mental Retardation, and Multiple Disabilities has been passed in 1999. It is important because we'll come later know about the National Trust. And the Rights of Persons with Disabilities, RPWD, has been passed in 2016, which was previously in 1995. It has been replaced, and recently we are following the Act that is of the 2016. For the differently abled people, the first thing that is for the accessibility to reach to the clinic, to reach to the hospital or any kind of place. So there is certain guidelines which have been made by the government, and these guidelines can be downloaded from the website. They are easily available, and it is a simple PDF. It is for basically planning of infrastructure or the harmonized guidelines and standards for the universal accessibility in our country. These guidelines are for the ramp, for the track, for the buildings, for the parking area. Everything has been planned other than the dental clinic. We have one unique disability ID program under the Department of Empowerment department, and under this UDID website, UDID card scheme, you will come to know about the schemes for the person with disabilities. There are various schemes are there into the website, and once you'll go to the different schemes, you'll come to know about the medical schemes also, which are helpful for the UD as a UDID card to the differently disabled people. This UDID project is under the federal government of India, and it is basically to create a national database for the person with disabilities. And this card, the card which is provided, it is valid throughout the country. Through the card, the people, they are getting scholarships, they are getting the school education, they are getting the sports facilities. So from this card, they are getting various kind of facility, which is through the UDID card. And we'll come to know what are the different benefits of the UDID card. But it is basically kind of Aadhaar card which we have. And this UDID card is for differently abled people, which is known as Ek Divyang, Ek Pehchan. And this card can be used for the traveling, for the banking. And this card can be utilized for the medical support also. But regarding the health needs, what general people are utilizing, that is Ayushman Bharat. So is it there that this scheme, Ayushman Bharat, is for disabled people? Whether such a scheme provides some kind of financial benefit also to the people, it is yes, it is no, or it is helpful to some extent. So as per the recent data which is available, Ayushman Bharat is not for the disabled people, because certainly disabled people, they have multiple kind of problems, and their general requirement of the health, their other requirement of the diagnostic aids, it is comparatively more as compared to the other people. So Ayushman Bharat does not cover the any kind of financial support. to the disabled people. So if Ayushman Bharat is not covering, so how will come to know what are the different kind of schemes for such children? So if we'll go to the website of the DEPWD, there are almost 230 kind of schemes which are there, and these schemes are given by the central government of India, as well as some of the schemes are supported by the different states. As in this slide you can see, there are various schemes, and some like one example is given from the Gujarat, other one example is given from the Kerala. So these are the different kind of schemes which are available, and they are giving like medical treatment, they are giving prosthetic support, they are giving hearing aid, and they are giving hospitalization support also. As you people are from the different states, you have to go through also, and you have to understand what kind of a scheme is implemented in your state and whether it is supporting dental treatment also for these people. Our country, they recognize 21 different kind of disabilities. It is a broad term because in a single disability, there are multiple different issues also which are covered. For example, if it is a blindness or low vision, so partial vision loss, low vision, or complete blindness. If it is a hearing impairment, so partial hearing impairment, or completely deafness, that is also covered. Even if we are covering about the blood disorders, so multiple kind of blood disorders are there. So out of these 21 different kind of disabilities, there are so many issues, so many disabilities are also covered. That is why through the Ayushman Bharat, through the central government of India, it is not possible to cover all kind of people under this scheme. That is why they do not provide any kind of financial support or medical aid under the Ayushman Bharat scheme. So if they are not providing, what are the other solutions? What are the other things which are there for them? So DPW department, that is a nodal department for implementing various programs, schemes, and other initiatives for the welfare of persons with disabilities. One is DDRC, which is known as District Disability Rehabilitation Centers, and other one is ADIB, that is known as Assistance to Disabled Person for Purchase. What is DDRC? DDRC are provided with financial, infrastructural, administrative, and technical support by the central and state governments, so that they are in a position to provide rehabilitation services to persons with disabilities in the concerned districts. Other one is needy disabled person in procuring standard aids and appliances to promote physical, social, psychological rehabilitation of person with disabilities. So under these two parts, which are basically for the different districts, under these programs, some kind of financial support is provided to them. If we are going to help them, or they want some kind of advice, some kind of the information, so as a doctor also, you can go to this line number, or you can ask the patient parents, patient guardians to reach to this helpline, and these helpline number people, they will help the needy person regarding the medical aid, regarding the support for their health problems. The information for the parents or even for the dentist, it is given onto different kind of platforms, like various kind of disabilities, what kind of disabilities are covered. The information to the parents, it is given onto the Vikaspedia, and there is a audio guide also, which is helpful for the parents. That is why these parents will go and listen about the different schemes and what scheme is useful for the parents. And through the NGOs, through the different kind of government employees, it will be a common discussion that in their state, what scheme is there and how these schemes will be helpful for the betterment of the child. The card, the UDID card, which we have discussed earlier, there are three kind of different cards. One is for the less than 40% disability, other one is more than 40% but less than 80%, and third one is for the more than 80% disability. So these cards are helpful. Once they have this, so they can show this card to the hospital or clinics, and through this card they will get some kind of financial benefit. And what kind of financial benefit will be there, that we will discuss in this slide. We have discussed earlier, there is a national trust which was made in 1999, and under this trust there is one scheme which is known as the Niramaya Health Insurance Scheme. This scheme is very much useful for us because in this scheme there is insurance cover up to 1 lakh on reimbursement basis. It provides same coverage irrespective of the type of disability covered under the National Trust Act. Services ranging from regular medical checkup to hospitalization, therapy to corrective surgery, transportation as per the benefit, chart issued, revised by the National Trust, which may be revised from time to time. Treatment can be taken from any hospital or from any clinic. So under this scheme, up to 1 lakh treatment cost is provided. Even the transportation charge is also provided. And under this scheme, any kind of disability treatment, diagnostic aids that are provided. What kind of the benefits are there? Let us understand. So in this table, as per the second point, the OPD treatment including the medicine, pathology, diagnostic tests, and up to the 8,000 rupees they are covered. In the third point under 2 category, that is dental preventive dentistry, up to 2,500 rupees, the treatment cost is provided. So this is like 8,000 and 2,500, means almost 10,500 support is given to the differently abled people. And this is all under the scheme that is known as the Niramaya Health Insurance Scheme. We can take, as a dentist, we can take advantage of this scheme if the families, they have registered their child under this scheme. If the NGOs, they have a group insurance or they have an individual insurance of their candidate under the scheme, so they can take the benefit. In the district hospitals or into the various kind of centers, we have a provision of early intervention center. We can understand what is the EIC. This unit should have enough space for providing facilities in separate rooms, including various things like physiotherapy, occupational therapy, speech and language therapy, counseling support, family education, preparatory. But pediatric dental care for special healthcare need is not there, and it has to be included in future. They have the dental setup out of some state, some district intervention centers, but pediatric setup is not there. We have to go ahead in various terms, like every government district hospital should have an EIC alongside the district early intervention center. These EIC must be set up in every primary health center and community health centers. Anganwadis and Asha Karyakarta must be trained about EIC. All pediatricians, whether they are from the government or from the private, in the state must be trained regarding the early intervention center. That is basically EIC cum preparatory school. Health, women and child and social welfare departments in the state and the district level should work together in this direction. Direct training in basic knowledge in early intervention will help in creating strong community awareness, and a national program in this area needs to be formulated to provide necessary support to the states to achieve their sustainability innovation mode. That is a kind of thing which we are planning, and that is a goal which we have to achieve in coming days. What are the basically core services of EIC? They provide medical services by a pediatrician or a medical officer. They provide dental services, occupational therapy, physiotherapy, speech, clinical psychologist, optometrist, laboratory technologist, data entry operator, and a special educator. But as per the dental services, appointment or services through a pediatrician, pediatric dentist, it is not there. It is provided by a general dentist, and hopefully in future days, we will have appointment of the pediatric dentist and district early intervention clinics. We have to read a lot of regarding the services to provide it. These are the different study materials which I have read, and various websites also there which I have mentioned earlier. From the PWD website, you can go there and you can read about the various schemes as well as the different policies. Here, I would like to remind you basic points. Special healthcare need is a specialized branch like pediatric dentistry. By seeing a child, you have to first think that you have to keep it is empathy, because these parents are already suffered a lot from since the birth of the child. So first thing we have to ensure them, we have to give a empathy, and that is a building of a trust between the dentist and the parents. Taking of special healthcare children is important. Tracking. Rehabilitation of dental issues should be considered. A team with dedicated staff is mandatory. Whether it is a nursing staff, whether it is a dental assistant, you have to train your staff regarding the handling of these special healthcare need people. And since pediatric dentistry is a promising branch, same with the special healthcare need children, that is a special care dentistry. It is again a promising branch. I am doing the special care need children treatment. Since I learned since I have done my certificate course, I belong to the first batch of this certificate course, and since 4 years I'm working in this, and really it is a very much promising branch. Small video, it is for you.
I think volume is not there in the video.
The volume is not recorded.
If they could play it again with the volume.
Have to ensure that we have to give our empathy. That is a building of a trust between the dentist and the parents. Taking of special health children is important. Tracking. Rehabilitation of dental issues should be considered. A team with dedicated staff is mandatory. Whether it is a nursing staff, whether it is a dental assistant, you have to train your staff regarding the handling of the special healthcare need people. And since pediatric dentistry is a promising branch, same with the special healthcare need children, that is a special care dentistry. It is again a promising branch. I am doing the special care need children treatment. Since I learned since I have done my certificate course, I belong to the first batch of this certificate course, and since 4 years I'm working in this, and really it is a very much promising branch. Small video, it is for you.
Audio is not recorded.
Sir, the volume is not there. We cannot hear.
Okay, I can update about this video. It is a small clip from a movie that is Chandu Champion, where this actor, he was suffering from the lower limb paraplegia, and he was a national Olympian winner under the Paralympics. So he's just giving small details about how the special people are being discriminated and how they are not being given the chance for participation.
So this was a small video regarding the sensitization of our people, and these are the various programs which I regularly do with the help of my staff, my PG students, and it is like contacting NGOs. It is going there, screening programs, and if the people, those who are requiring treatment, we tell them that the facilities are available in government hospital, and we deliver the treatment if it is possible in the clinic, or if it is required, we treat them under J also. So I am very much thankful to the people, those who have given me this opportunity to learn to serve the special needy people, and special thanks to Mosby Madam and Nikhil Srivastava sir, who has taken the initiative, and to the ISPPD people who has given me the opportunity to present here. Thank you very much to all the people. Thank you.
Thank you, sir. It was a very nice presentation and a great service to the society also. So there are some questions in the chat box. The first question being, sir, a lot of special healthcare need children need treatment under general anesthesia. Could you please confirm if the government covers it under any scheme? and it is based on the BPL or APL cards.
Yes, madam, regarding the treatment for special healthcare need under general anesthesia. So, as per the government hospitals, they generally provide the full complete treatment without any charge. It is free of cost. I'm not confirm about different states, but in our state like Madhya Pradesh, it is completely free here. So maybe with some discounts, maybe some kind of concession is there, but otherwise it is almost free for the special healthcare need children.
Okay. Thank you so much, sir, for the information. Is there any other questions from the participants?
Shivamar says, Composite Regional Center for Persons with Disability Service, Eradunda Panchayat, Government of India. Sir, can you elaborate on this, sir?
That is a composite regional center which was started a few years before. We keep visiting, and our department is also attached to that particular thing. What all the different facilities which are required for this type of children, they are there in that particular center, because it is a regional center for this area, like sensory adapted environments, and then different other occupational therapy, everything. They're all there available for children there.
Thank you so much, sir, for your very good information regarding special healthcare needs. Sid Kumar, sir, thank you so much.
Yeah,
for
one more
joining
thing I
us.
want to add.
Yes,
Please.
sir.
There are different NGOs, those who are taking care of special healthcare need, maybe some schools for children with blindness, maybe children with having some kind of mental retardation. So these NGOs are also getting some donation from societies, and they are also coming to us where they are ready to pay if there is some medication and some
Your voice is breaking.
Sir, there is some disturbances. We cannot hear you properly, sir.
Shall I speak again?
Yeah.
Yes, sir.
Yes,
Please.
yes.
Please.
Required for the treatment.
Asif, sir, will you please kindly repeat again, because this mic was mute, it seems, when we were speaking, when you were giving the answer, we cannot hear you properly.
Okay. Now I'm audible to all.
Yes, sir. We can hear you now.
Okay. There are some NGOs who are having
Yes,
some financial support also. So for children treatment, they can pay some amount to the clinics or to the hospitals. While we are talking about the government hospitals or the government colleges, they have schemes where the completely free of cost treatment is provided to the special healthcare need. It may be different for different states, but generally for a government hospital, it is provided free.
Okay. Thank you, sir.
Thank you.
Yeah,
Thank you so much, sir.
our college is a private college. When we have asked for the reimbursement, what they said is that only 2,500, as you have shown in the Niramaya card, only that can be reimbursed actually. So that is a sad part actually, because once the charges, everything for the hospital comes around minimum 30,000 rupees. So that may not be, because first one is accessibility. So I think the association and all of us should go for it to get the reimbursement for at least for the special healthcare needs, because they may not get all these things from outside. If they go to private hospitals, it'll be a huge amount actually. And I don't think so how many government hospitals are there to take care of these children. So I think the insurance has to be there for these children and the amount has to be covered.
Right, sir.
Yes. Lakna ma'am, you can conclude.
Thank you, sir, for your insights. A great presentation, and thank you for this opportunity. We also we are always focused on oral health of these children, but it's time to also bring about new policies. And using ISPPD, I think we should be able to drive towards treating them holistically as well, and guiding the caretakers to be able to avail these facilities that we have in the government. Thank you.
Thank you, sir. Can I have the certificate? Can you accept the certificate, sir? Can I have the certificate for the speakers also? Ma'am, thank you, ma'am.
Thank you so much, sir.
Thank you so much.
Thank you, Bhumika ma'am. Bhumika ma'am.
Thank you so much for the opportunity.
Thank you. So we are moving to the last session, that is anticipatory guidance in club children, what every pediatric dentist should be doing, by Dr. Priya Seth. And this session will be moderated by Dr. Tareen Emmeti sir and Dr. I.K. Pandit sir. We welcome you, sir. Dr. Tareen Emmeti has completed his BDS in 1989 and MDS in Pediatric Dentistry in 1993 from Manipal University, along with BSc from Calicut University, Kerala. He has held academic and clinical positions in reputed institutions in India and abroad, including Manipal, King Khalid Hospital, Saudi Arabia, Annamalai University, and Sri Ramachandra Dental College.
बट उसका फोन दस कैजुअल फोन कर वापस कैसे मीटिंग कर क्या प्रॉब्लम आए
And served as a professor and head of the department at Annu Dental College, Kerala. Currently, he is an exclusive pediatric dental clinical practice in Thrissur and is associated with Thrissur Institute of Head and Neck Surgery. An accomplished academician, he has numerous publications, textbook contributions, and lectures to his credit, and has actively served in the professional bodies like Indian Dental Association and Kerala Association of Pediatric and Preventive Dentistry in leadership role. We welcome you, sir. Dr. Indrakumar Pandit completed his BDS and MTS from King George Medical College, Lucknow, has become the youngest dean or principal and director at DB Sanitary Dental College, Eminanagar. Serves as a professor and head of the Department of Pediatric Dentistry with over 35 years of academic and clinical and teaching experience. A gold medal awardee for the excellence as principal. He has over 200 publications, 70 plus research projects, and multiple international research grants. He has held the key leadership roles, including Vice President, Dental Council of India, Haryana State, and the past President and Secretary General of ISPPD. He is a patron and governing body of SAPPD, a keynote speaker at 200 plus forums, editorial board member, reviewer, and fellow of reputed academies, an active member of several professional organizations. We welcome you, sir, even with so much of difficulties. I know that. Thank you, sir, for joining with us.
Thank you very much, Dr. Andana. Thank you very much, Dr. Tarian, for joining with me.
Hi, Dr. Panditji. Very happy to share the podium with you. Thank you, Anand, for that introduction.
Thank you.
So
I have been given this a great chance to introduce Dr. Priya Seth, and she will be speaking on anticipatory guidance in children and what pediatricians should be knowing about this anticipatory guidance. And I am really keen to listen to her and some introduction about Dr. Priya Seth. She's a pediatric dentist who graduated with honors from A.V. Shetty Institute. It is a prestigious institute, receiving A.K. Munshi Gold Medal. A.K. Munshi has been the professor and teacher of my wife also, and my senior colleague, my elder brother like. She works as the only pediatric dentist in a multidisciplinary team at the Cleft Leadership Center, Bangalore, a globally recognized unit. The center is amongst the 5 leadership units worldwide assigned by Smile Train, pioneering oral health programs across partner hospitals. Dr. Priya collaborates with Smile Train Advisory Committee to establish the oral health care standards for children with cleft lip and craniofacial differences globally. Her focus on preventive and comprehensive care aims to create sustainable oral health models for low and middle class income countries. She has managed over 1,200 children with cleft lip and craniofacial conditions, striving to achieve caries-free lives for these children. She has strong interest in airway dentistry and works towards integrating holistic care approaches for children with cleft conditions. Really, a great enthusiast and our fellow pediatrician, we welcome you, Dr. Priya, and the podium is for you. And you can just sensitize people about your experiences and your vision towards what we are going ahead of. Thank you.
Thank you so much, sir, for those kind words. Thank you so much. It's an absolute privilege for me to be here. I can't be more grateful to the entire team, Mausami ma'am and ISPPD for this opportunity. As opposed to most of the lectures that have been given this far, mine is very clinically oriented, and I'm hoping that everybody gets a little gist of what I have been doing, and I hope to learn further from each of you with whatever you all have to opine over the work I'm doing. Thank you so much.
A very good afternoon to each of you here. I would first like to congratulate each of you who chose to empower yourselves with deeper knowledge from the experiences of those who treat us special ones routinely and have been doing so for years. 3 years ago, being part of one of the first batches of this certificate course, my understanding deepened, and I'm ever grateful for the conceptualization of this course, and I completely align with its vision. My heartfelt gratitude to Mausami ma'am, Kavita ma'am, and ISPPD for giving me this opportunity to share my work and the little experience I have in the world of comprehensive cleft care. I'm Priya Sheth Mehta, a pediatric dentist at Smile Train's Cleft Leadership Center in Bangalore, and I've had the privilege of working with over 1,200 children and families that are affected with cleft in the past 5 years. This made me realize how anticipatory guidance can change the course of the journey for not just the child, but even the parent, and reduce their burden of care significantly. So here's presenting anticipatory guidance in children with cleft, what every pediatric dentist should be doing. Before I begin, this is my gratitude to my alma mater, the reason I found my purpose of serving children with special healthcare needs. So that's A.B. Shetty, where I studied my post-graduation and found my purpose. This is my place of worship, the place I work at, and my wonderful team, thanks to whom I am here today. We have one single motto, that's patient comes first. We all have this shared mission, and we follow this to the T. This is one single line or motto that can change the way we practice in general. So if we keep the patient at the pinnacle of or at the apex of the triangle, there will never be anything wrong that you will do intentionally. And it will only allow you to keep deepening your knowledge and understanding to provide better in terms of service, in terms of explanation, in terms of understanding, and a lot more. So we follow this one single motto, and it has definitely changed the way I practice clinical dentistry. So as you see here, this is an overview of what came to me before pediatric dental clinic was set up in the comprehensive cleft care unit. You can see a 2-year-old, a 3-year-old, right up to a 9-year-old. And each of them have severe early childhood caries, not just ECC, but severe ECC. The question here is not what could we have done or what to do. That comes a lot later. The question here is actually, where did we fail or what went wrong? What did we miss? Where could we have intervened and changed this narrative? So that's exactly coming to children with cleft care are not just surgical patients. And this is extremely important for not just the team, but us as pediatric dentists to understand that just looking at a child with cleft shouldn't make it difficult for us. We shouldn't be stepping back thinking we don't know enough, because a child with cleft is very similar to a child without a cleft. The only difference majorly is the physical defect that is there in the palate or the alveolus, and just understanding a little about how things work around that area will allow us to provide to them the same services, the same guidance that we would do to any other child. So children with cleft are not surgical patients. They are high risk dental patients right from infancy. So in cleft care in general, we usually see the patient right since they are born, almost since they are just about born. So this allows you to spread the message to the child, to the parent and the family very early on. We don't really need to wait for them to have the kid come to us. They are anyway coming to the team. They're anyway going to the cleft care team for multiple other issues that are being addressed. Just attaching yourself to a cleft unit and providing simple anticipatory guidance can be life-changing for the patient as well as for you, because it teaches you so much in terms of how much we can prevent and avoid, and we don't really need to get to a point where we have to treat at all. So what is anticipatory guidance? It is basically the process of providing practical and developmentally appropriate information about child's health to prepare the parents for a significant physical, emotional, and psychological milestones as given by AAPD in 2025. Now, anticipatory guidance is an array of things. It's not just one single thing. There is oral hygiene practices, there's oral dental development and growth, certain habits that are developed over time, speech and language development concerns, diet and nutrition, orofacial injury prevention, and substance abuse that comes in as the child grows. So it is not just one single thing, but today I will be concentrating more on oral health and guidance in terms of dental health, because if I cover everything, it's going to be way beyond the time that is given to me. So let's just concentrate on one single thing, that is oral health guidance, anticipatory guidance for the family, which can help not only children with cleft, but any child that has special healthcare needs or doesn't. This is a prototype for every child in general. Let's walk through this stage by stage as the child grows. So the first stage is birth to 6 months, one of the most important and challenging stages for both the child as well as the parent. It's very overwhelming for the parent, because this is when they have just about seen their child have the cleft, whether they knew about it prenatally or not. They've now seen the physical challenge that the cleft has with it. They are unable to feed the child appropriately because the cleft palate does not allow appropriate suckling, it does not allow the suction, it doesn't allow the breast pumping enough milk into the mouth. There is nasal regurgitation, prolonged feeding times, there could be pain in the mother's breast, and a lot of anxiety. All of this directly is linked with the child's weight gain as well, because what happens when the child does not feed well is that the child tends to lose more weight than gain. As the child is suckling milk, then the caloric expense is greater than the actual intake of calories. it does not allow the child to gain weight as would be in a child that does not have a cleft. So this is one of the major concerns for the parents as well as for the surgical team, where the child does not gain weight. So another very important factor is pre-surgical nasoalveolar molding. It is another very stressful procedure in cleft care, where the parents have to be handling the NAM appliance in the child's mouth, and it can be extremely overwhelming. They can be very apprehensive with using this device because they're scared with the cleft alone, and now they're going to have to put things in and out of the mouth that exerts force and allows the child to cry a lot more. So that's another challenge. And finally, there's also surgery scheduling. So these are the major challenges that are anticipated in this 6-month period. So what can we as pediatric dentists do to ease this out for them? The first is teaching them how to feed well. Now, to feed well, certain basic things remain the same, where the child should be able to breathe properly, the nose should not be compressed by the breast, the child should not cry during breastfeeding to avoid aspiration, and the mother should allow the child to breastfeed on either breast for a minimum of 5 minutes each, so that it allows the milk production to be increased, and the skin-to-skin contact of the mother and child is also maintained. Each meal must be completed within 20 minutes because, as I mentioned earlier, the caloric expense should never exceed the caloric intake if we want weight gain. And mothers during breastfeeding must be very stress-free and relaxed. Now, this is an interplay of hormones at the end of the day. And if the mother is going to have a high cortisol, it is going to be difficult for the milk to be produced in enough volume for the mother to either express or to be able to directly feed the child. So psychological counseling of the mother is a very, very important missed feature that we as pediatric dentists can help fill in when it comes to this time period anticipation of challenges. Feeding frequency should be within 2 to 3 hours. Every 2 to 3 hours, the child must be fed either expressed or direct breast milk or the formulas as is required and suggested for the child. Burping is extremely important because this allows us to understand that the child has not aspirated the milk and also to ensure that the child directly digests this feed. So the child should be held well across over the shoulder and need to burp at least 2 to 3 times during each feed.
Is there an audio problem? Is there an audio problem?
Yes, sir, the audio got stuck. That's fine.
Okay, fine. Please inform.
Can you restart? Restart it.
Yes.
Let's walk through this stage by stage as the child grows. So the first stage is birth to 6 months, one of the most important and challenging stages for both the child as well as the parent. It's very overwhelming for the parent because this is when they have just about seen their child have the cleft, whether they knew about it prenatally or not. They've now seen the physical challenge that the cleft has with it. They are unable to feed the child appropriately because the cleft palate does not allow appropriate suckling, it does not allow the suction, it doesn't allow the breast pumping enough milk into the mouth. There is nasal regurgitation, prolonged feeding times, there could be pain in the mother's breast, and a lot of anxiety. All of this directly is linked with the child's weight gain as well, because what happens when the child does not feed well is that the child tends to lose more weight than gain. As the child is suckling milk, when the caloric expense is greater than the actual intake of calories, it does not allow the child to gain weight as would be in a child that does not have a cleft. So this is major concerns for the parents as well as for the surgical team, where the child does not gain weight. So another very important factor is pre-surgical nasoalveolar molding. It is another very stressful procedure in cleft care, where the parents have to be handling the NAM appliance in the child's mouth, and it can be extremely overwhelming. They can be very apprehensive with using this device because they're scared with the cleft alone, and now they're going to have to put things in and out of the mouth that exerts force and allows the child to cry a lot more. So that's another challenge. And finally, there's also surgery scheduling. So these are the major challenges that are anticipated in this 6-month period. So what can we as pediatric dentists do to ease this out for them? The first is teaching them how to feed well. Now, to feed well, certain basic things remain the same, where the child should be able to breathe properly, the nose should not be compressed by the breast, the child should not cry during breastfeeding to avoid aspiration, and the mother should allow the child to breastfeed on either breast for a minimum of 5 minutes each, so that it allows the milk production to be increased, and the skin-to-skin contact of the mother and child is also maintained. Each meal must be completed within 20 minutes because, as I mentioned earlier, the caloric expense should never exceed the caloric intake if we want weight gain. And mothers during breastfeeding must be very stress-free and relaxed. Now, this is an interplay of hormones at the end of the day. And if the mother is going to have a high cortisol, it is going to be difficult for the milk to be produced in enough volume for the mother to either express or to be able to directly feed the child. So psychological counseling of the mother is a very, very important missed feature that we as pediatric dentists can help fill in when it comes to this time period anticipation of challenges. Feeding frequency should be within 2 to 3 hours. Every 2 to 3 hours, the child must be fed either expressed or direct breast milk, or the formulas as is required and suggested for the child. Burping is extremely important because this allows us to understand that the child has not aspirated the milk, and also to ensure that the child directly digests this feed. So the child should be held well over the shoulder and need to burp at least 2 to 3 times during each feed. Now, when it comes to feeding, as I mentioned, if we are doing the direct breastfeed, there are two major positions that we suggest mothers to hold the child in. So if it's a unilateral cleft lip, then we train the parents to position the child in a manner that the cleft is towards the breast, and this allows the breast tissue to provide the absolute required amount of seal. What the breast basically supports this seal as it shuts off that cleft area with the breast tissue. So as you can see in this in the image here, the child's cheek is supported so that the cleft can be the cleft width is reduced with the breast tissue itself. And this further allows a good seal. Now, the child should at all points of time be in an upright position because we don't want aspiration of the milk. If the child has a bilateral cleft lip, then a dancer's hold, that is holding the child in a manner where the hand is such that the last 3 fingers support the breast tissue and allow expression of milk, and the thumb and the forefinger cup the face of the child or the cheek, support the child's cheek, cradling the chin well to create the suction or the seal with the breast tissue. This allows the child to press against the nipple and the areola between the gum pads, and the child should be held in an upright position as is a standard protocol in whether we breastfeed, whether we formula feed or pump express breast milk feed, and burp the child every 5 minutes for 2 to 3 times through the feed. So let's see if the child cannot be breastfed. We ask the parent to express the breast milk and then feed the child either using a palada or a spoon. Out here, we have a video of the child being fed with the palada. This is a modified dancer's hold where the child is held from the back in a manner that the milk is slowly poured directly into the mouth. So as we see, there is just milk being given in a drop format into the child's mouth. This allows them to directly swallow the milk. Now coming to another very important challenge in this time frame, that is natal and neonatal teeth, which is very commonly seen with children in with cleft differences. So usually if present and not mobile, we don't do anything to these teeth. We just allow them to be. Of course, if the tooth is very mobile and there is a very sharp edge, then either extraction or grinding of the sharp edges is considered. And this remains the same whether the child has a cleft or not. The care is the same. But yes, because it is very commonly encountered, it is important to anticipate this and also inform the parents that this is absolutely not an abnormality or to be worried about. And the presence or absence of this tooth is not going to directly impact any future permanent teeth that come out, because that is their primary concern, that will my child look normal at the end of the day. So we have to reassure the parent that this is present. It's absolutely all right. Care needs to be taken that the tooth is not aspirated, and the moment they feel that there is any form of movement or mobility of the tooth, they must report to the dental clinic. And if there is no such issue of mobility or sharp edge, then we just let it be as is and teach them how to clean this tooth well so that there is no bacterial colonization this early in the child's oral cavity. Weight gaining, that's nutritional counseling, as I mentioned. The caloric intake and caloric expense must be calculated. If a nutritional support is available, that is the best to take. And if not, then we can help with the nutritional counseling where we directly measure how much feed goes into the child in the day. A food diary is supposed to be maintained by the parent for a week. And then we follow up with them as to how you can increase the nutritional provision for the child as exposed to the caloric expense. So this is very important, as seen out here with nutritional counseling. We were able to achieve a gain in the weight for this child over a period of 5 months, where the child was 2.4 kgs when they came to us. And finally, in 5 months' time, the child is now 6.4 kgs and ready for surgery. Coming to the pre-surgical nasoalveolar movement. So, as I mentioned, it's very important for us to pre-inform the parent what they are signing up for when they agree to take up the NAM procedure for their child. So we first show them these videos of how they will place the NAM appliance, how they must remove the NAM appliance. Once they remove the NAM appliance, it is important for them to clean this appliance well with a gauze, completely cleaning between the ridges is important because it invariably catches a lot of saliva. And finally, how to place it back in the mouth without directly causing any discomfort to the child. So this is taught to the parent prior to them, before we take them on for their NAM procedure. Now, one of the simplest yet most powerful interventions at this phase that we can introduce is oral hygiene before the teeth erupt itself. So very often the parents are very hesitant because they're afraid of, hurting this cleft area. So this is where we have to reassure them or teach them how to take care of this NAM appliance as well as the oral cavity, where we will teach them how to wipe the gums in gauze. They dip the gums with them and clean their entire oral cavity with the gauze, especially the cleft segments, and ensure that there is no stagnation of milk, a pooling of milk around the cleft segments post their feeds. So if they don't get cleaned well, then of course this becomes their first point of bacterial colonization. A lot of parents at this stage say that they had no idea that they could clean the tooth or the mouth, clean the mouth before the tooth even erupts. So it is very important for us to reassure to them that it is important to clean the gum pads, the mouth, the tongue, even before there is actual eruption of the tooth. This sets base for the child to accept any form of oral hygiene measures from the very beginning. This falls true for any child, whether there is a cleft or not, where the oral hygiene practices should be introduced before the teeth come in so that the oral cavity is stimulated enough to accept something going inside and cleaning it after every meal. They themselves will not feel good if they are not cleaned well after every meal. Now moving on to the next phase, that is as the teeth are going to start erupting, there are newer challenges that we're going to be seeing. So there's enamel hypoplasia, usually near the cleft area. There will be early childhood caries, and there will be post-surgical fear or hesitation in maintaining oral hygiene. So often after the palate is repaired, there's stitches inside. So that scares the parents or the caregivers, and they don't feel comfortable to maintain good oral hygiene. So this is where our role again comes into play, where we must ensure that the child brushes a brush and a fluoridated toothpaste. Yes, as young as this, we need to introduce fluoridated toothpaste and explain to them the quantity of usage so that there is not any concern of fluoride concerns that these fluoride lobbies have created in with all the advertisements that they have. So it's very important as pediatric dentists for us to completely reinforce the importance of a fluoridated toothpaste and the quantity as well. When we strongly counsel them against night feeds at this point in time and using any form of sweetened medications, a lot of times post surgery, there will be medication that will be prescribed to the child for pain management, and we must ensure that the cleft team is well aware of the harm that sweetened medication can cause, and now several syrups are even available without sweetened formulas, so that it can be suggested or Post-feeding medication, care should be reinforced. So they have to care for the oral hygiene, specifically after any feed and any form of sweet. This is also that period where they are now switching from milk to semi-solids to slowly solids. So the importance of oral hygiene cannot be even slightly missed at this point in time. So rinsing after every meals, of course, the child may not know how to rinse themselves, but teaching the parent how to wipe the teeth after every single meal and how important it is something that we can do at this point in time for the children. Moving on to 12 to 24 months, which is the high risk window for early childhood caries. Now, very often we see that children are bottle fed during sleep times. So they may not have weaned the child off specifically because the child has a cleft. There is this increased attachment that the parent has, or this increased guilt that the parent has for the child, because the child is not normal in normal terms or not healthy. So they tend to want to provide more as compensation for this physical defect that is there in the child. So it is important for us to teach the parent, train the parent that it's absolutely all right for the child to not be over pampered or for not every demand of the child to be met. And the first step towards that is the weaning of bottle feeds or at-will feeding. And that can be the first step for not only the parents, but also the child to understand and be disciplined in life. Bottle while sleeping is an absolute no-no, and training them how to wean this off is another very important fact. What I usually do is I tell them to start with diluting the milk in the bottle instead of directly throwing the bottle away. So when you dilute the milk, the first week you dilute it as 50-50, where the milk is diluted with 50% water. The second week, it's diluted with 3/4 of water and 1/4 milk. And finally, in the third week, the milk is supposed to be barely just enough to give those slightly whitish color to the bottle with water. Usually by this point in time, the child would have already been weaned off the bottle, and there is less concern of bottle milk pooling in the mouth. However, if this still doesn't happen, then training the parent to be refilling for 2 weeks of absolute sleepless nights and weaning the child off with complete or absolute abstinence from milk bottle is the only other way forward. Another very important factor is, like I mentioned, sugar exposure. Sugar exposure specifically through syrups, because the child may catch a cold, they may catch, and most of these formulations have sugar. Today, thankfully, sugar has become such an obvious criminal, not in the pediatric dental world, but also in the world of pediatricians. They are also now prescribing sugar-free syrups, and that is a big, big savior for all of us. So looking into what they are prescribed and understanding which syrup should and should not be prescribed is extremely important. In a lot of cases, this is where the first lesions usually begin. So our role becomes very structured, where we need to be very specific in our instructions of caries risk assessment, where we assess the various features, that is their diet, the parents' oral hygiene status, the ability or the understanding of the parents, because most of these are very low socioeconomic backgrounds. They don't really understand how important it is to maintain a good oral hygiene and what role oral hygiene plays in the development of the child in general. So all of this plays a very important factor in our assessment of being able to provide prevention to them and what kind of prevention is required. Counseling specifically with processed and sugar foods, not just sugar, but even things like bread, processed cheese, things like this are very important for us to reinforce. Biscuits, one of the most important instructions that I have realized has brought about a world of a difference in the Kerry's incidence in my practice is absolutely avoiding the use or the provision of biscuits to children. So biscuits often becomes a very easy snack and breakfast for most of these children, where they just dip it in milk and give it to the child because they think it's easy, it's energy, high in energy and good for the child. But so important for us to reinforce that no biscuit is healthy for the child, regardless of what an advertisement may say. No biscuit is going to be able to provide what your homemade upma, idli, poha, semia, and things like this are going to provide the child. So very, very important to reinforce to the parent that your home cooked meals are very, very essential and much healthier than a biscuit that you're going to provide the child, even though the biscuit may be a very easy provision to the child at that point in time. So diet counseling has to be not just a 5-minute thing, but a detailed understanding with the parent and the child. And of course, our age-old favorite, fluoride varnish. Application of fluoride varnishes at regular intervals will allow the child to, the tooth to basically have that ability to fight any form of decay that may start to produce. Now here we see how not just teaching them but you're telling them to brush your teeth. Like a lot of times we scrub technically but a lot of times the tooth that is rotated in the cleft area gets missed. So it's important for us to teach the parent to brush every single tooth and not just scrub through the oral cavity, but scrub the outside surface, the inside surface, as well as the occlusal surface for every surface to be completely cleaned and scrubbed off twice a day. So this becomes very important to show them how these things are done, and only then will they actually learn how to do them for their own children. Now moving on to 2 to 5 years of age, we now begin to see malocclusions, crossbites, enamel defects, and even mouth breathing. At this stage, our focus is primarily on oral hygiene independence, diet counseling, sealants and fluoride application, monitoring the enamel hypoplasia, and airway screening. So I'll run you through each of them one by one. As we see out here, there are certain crossbites that begin to develop very early. And if you realize, there is hypoplastic teeth also that are present. I'm not sure if you can see my pointer, but well, hypoplastic teeth pose one of the most major challenges in caries prevention. There was an article by Muthu sir in the Caries Research Journal that stated that developmental enamel defects are primarily the cause of decay before any of the other triad that existed. It is the tooth itself which can increase the susceptibility to decay, and in children with cleft, enamel hypoplasia is one of the most common findings in the teeth. So reinforcing this understanding in the parents is extremely important. So teaching the child oral hygiene independence. Of course, we still need the child to be supervised while they brush, and at least once a day, the parents must brush their teeth. But this is where autonomy is usually developing in the child. So allowing the child to brush on their own reinforces this habit in the child. And then, of course, the parent should continue or complete the procedure, the brushing for the child. Sealants, extremely important for those with a very high caries risk. Invariably, all children with cleft have a medium to, that's a moderate to high caries risk. So the moment we realize that there is some lax in the maintenance of the oral cavity, we must seal the posterior teeth and reinforce oral hygiene measures. And finally, monitoring the enamel hyperplasia as we see out here. Repeated STF applications can be done to prevent this from catching decay, because the fluorapatite that is formed along these surfaces definitely prevent even hypoplastic teeth from demineralizing as easily as they would otherwise demineralize. So very important in this primary stage of 2 to 5 years is reinforcing hygiene, oral hygiene, from our end placing sealants and application of fluoride and monitoring their enamel hyperplasia. So here's a short video of how at this age it becomes extremely important to accustom the child and acquaint them to the entire dental environment. Because the child with cleft is not going to just be a pediatric dental patient, but is going to require orthodontic treatment and a lot more such treatment on the dental chair. So making the child comfortable with this dental environment in this particular age leads not only a positive dental attitude, but also allows the child to accept and understand that there is nothing threatening in this. So providing them simple fluoride varnish applications or oral prophylaxis at this point in time becomes extremely crucial and essential. Then going back with a smile on their face decides how the child will then feel and accept the treatment, and their compliance for even orthodontic therapy then is better. Another important factor, of course, in when we haven't been able to completely prevent, is where we have to identify early lesions and restore. So as we see out here, they're not very obvious decay, and the parent often misses this, but we must teach the parent to lift the lip and check and keep checking, and we must do the same as well. And as soon as we see initial decay, we should definitely restore it immediately. Either placement of SDF if the child is not going to allow, does not have cooperative abilities, and no form of pharmacological behavior management is accepted, then SDF is one of the best options. Even otherwise, I usually always suggest SDF to children with cleft so that there is at least arrest of decay, and then we can always provide them with restorative care once the child is more accepting of dental treatment. The next phase becomes a lot more complex. Now here we see mixed dentition issues. So what exactly do we face in this period is ectopic eruptions, crowding, supernumerary teeth, and difficulty cleaning because of plaque stagnation and appliances only increasing the difficulty. So as you see in the first image, you see there is absolute crowding. There are certain retained deciduous teeth and some supernumerary teeth as well, as also seen in the second image on the right, where we see that there has been the lateral tooth bud has been split. So there is, we can't really term this as gemination because they're two separate teeth altogether. So here it is a supernumerary tooth that has been developed by the splitting of this particular tooth bud because of the cleft. And finally, we also see how there is stagnation of plaque in this third image below, purely because there is so much crowding. It becomes very difficult for them to clean. So teaching them how to clean these teeth, introducing flossing extremely important at this point. And of course, the appliance is making it so difficult for them to clean in this absolutely crowded arch. Now, a palette also makes it very difficult for a brush to reach every tooth. So, prescribing certain specialized toothbrushes becomes another very important factor that can help them maintain their oral hygiene better. So, our approach at this age becomes a lot more intensive. We have to reinforce oral hygiene. We have to reinforce diet counseling because now the child is much more independent, going to school, getting plenty of birthday parties to attend, plenty of chocolates given during birthdays. Other children are eating chips and things like that. So diet counseling again becomes very important. Sealants and fluoride application again becomes the crux of our anticipatory guidance out here, where we have to ensure shorter recall intervals so that we can monitor the oral hygiene of the patient and intervene much before there is actually a cavitation that occurs in the tooth. We follow a very simple recall protocol from 6 to 8 years. When if the child does not have any appliance, that is a pre-orthodontic phase, then we recall every 3 to 6 months, 3 months for moderate risk, moderate to high risk, and 6 months for low risk. Because at this point in time, we have already established a good oral hygiene protocol. So if there is good compliance, then once in 6 months recall period is good enough. But if we realize the compliance is a question mark, parents are not really paying as much attention as we'd like, and of course there is also dental anatomical concerns like hypoplasia, then every 3-month recall period is followed. Orthodontic appliances, when in the mouth, invariably, good or bad, we call the patient every 3 months so as to reinsure or reinforce clean oral cavity and no form of PK that can develop as hidden caries, because a lot of times we miss seeing caries because of these appliances that are bonded onto the teeth. 8 to 12 years immediately post-surgery. So between 8 to 12 years, invariably the child with a cleft alveolus will undergo what is called a secondary alveolar bone graft for the incisor, that's the lateral, or the canine to erupt in that area through the defect. So when they undergo the surgery, again, the child and the parent becomes extremely anxious and apprehensive, and they are not very confident in cleaning the oral cavity immediately post-surgery. So at this point in time, calling them every month for at least the first 3 months and then every 3 months, it becomes crucial to ensure that the child is maintaining good oral hygiene in and around the surgical site. One, to allow proper surgical healing, and second, to ensure that there is no plaque stagnation in and around the surgical site once it has healed. The fluoride therapy that is provided is suggested by AAPD, where low caries risk is provided with just 1000 ppm fluoridated dentifrice. Moderate caries risk, which invariably most of our cleft children fall under, will be a 1500 ppm fluoride dentifrice and a biannual fluoride application, which is we usually apply a varnish. And a high caries risk will be not just 1500 ppm of fluoridated dentifrice, but also an antibacterial mouth rinse once every week and quarterly fluoride varnish application. So when it comes to antibacterial mouth rinse, in all honesty, what we do is povidone iodine washes, or 10% of povidone iodine is washed along the tooth surface, done every time they come to visit the speech therapist. So invariably in this period, children with speech concerns come to visit the speech therapist at least once a week or once in 2 weeks, and we ensure that we club the appointments with them and provide them with these povidone iodine washes, so that provides the antibacterial property weekly or bi-weekly to these children. So this is basically what we can achieve if we provide anticipatory guidance to these children. You see, there's absolutely sparkling teeth, and trust me with this, we have not done any form of intervention here except for maybe a restoration or two that was done much earlier than when the appliances were placed. So now that the appliance has been placed, the child has the ability to maintain it much, much better because they have had this prior understanding of how to maintain their oral hygiene. So this is what we basically are aiming to achieve when it comes to children with cleft in this time period of 6 to 12 years of age. Now here is what happens without anticipatory guidance. Say we don't inform the parent what we are supposed to inform them or what they should expect. Say they don't know what to expect. This is what we see. So this is exactly what will happen if we don't provide anticipatory guidance. This is exactly pictures from children who came to us at the dental clinic when the clinic was just about established. These are children who are 5, 6, 7 years and beyond that didn't have the opportunity to understand about their oral hygiene care. Multiple procedures were required, there was delay in the surgical timelines, and it was an absolute burden for not just the child, but even the parent to constantly get the child to the dental clinic to get their teeth fixed before any further procedure could be provided. Because this is deleterious to surgical outcomes as well as for orthodontic appliances. I mean, when there aren't any healthy teeth, where are we going to place the appliances? How are we going to realign the teeth? So explaining all of this becomes so important to the parent much in advance than we do later. And that is where anticipatory guidance plays its most important role. And this, on the other hand, is what success looks like. So a child who reaches adolescence with healthy teeth, minimal intervention, and an absolute readiness for every stage of cleft care. Now, as pediatric dentists, we are not just treating teeth. We want to prevent an additional layer of disease in these children who have an already very complex journey. So our role is so important in their development, not just physically, but even emotionally, even psychologically, in their developmental phases, where we need to keep reinforcing the importance of not just oral hygiene, but also hygiene in general for the child to develop much better than they otherwise would have. The parents are only concentrating on surgical timelines, and that's all their concerns actually are. So they often neglect oral cavity, which actually is the most important for good surgical outcomes eventually. So it is our duty to provide this information to them so that we can achieve this rather than what we saw earlier. Now, we may not perform the surgeries, but we influence every stage of the child's journey. And if we step in early, consistently and intentionally, we can ensure that the dental disease is never an added burden in an already complex life for these children. So we as pediatric dentists are the preventive gatekeepers of the cleft teeth. When we prevent decay, we're not just saving teeth, we're protecting the child from additional pain, fear, procedures that were not needed in the very first place. So anticipatory guidance is not an added step. In my opinion, it is the foundation of cleft care. Thank you very much. Thank you once again, ISPPD, for this wonderful opportunity of sharing the little work that I do at our unit. Cleft care often doesn't come under this umbrella of children with special healthcare needs because pediatric dentists haven't ever really taken active involvement, haven't been involved actively in cleft care. It is primarily a very surgical oriented field. And in every conference I have been to in the last 5 years, I'm one of the only 5 to 6 maximum pediatric dentists that exist. And I really hope this changes here on, because cleft is still a very, very, very big occurrence. 1 in every 500 children have a cleft. We have treated over 1,000 children with cleft in just 3 years. And there are only more and more that keep coming. But we as pediatric dentists can definitely make their journey easier by just providing very simple care, anticipatory guidance in 2 very simple words that explain everything that is actually required for the child to have the best life, by completely eliminating one entire factor of, or one entire burden of disease. So the least we can do as pediatric dentists is provide them with simple care guidelines so that they don't really require any form of intervention dentally, because they're anyway going to require all of it surgically and orthodontically. So I'm really hoping that this has given you all a better overview, and more of you will want to practice cleft pediatric dental care and provide more and more anticipatory guidance, not just to children with cleft, but every child in general. Our specialty is pediatric and preventive care. Pediatric and preventive dentistry, right? So preventive, in my opinion, should actually come in as the soul and the first, the very first thing that we can provide to every single child that comes to us. So I hope you all join me in my dream of KD's Free India soon. And thank you very much. If you do have any more questions or haven't understood something that I've explained, please feel free to reach out to me. Thank you.
Thank you, Dr. Priyal, for that wonderful lecture on cleft lip care and patients care, children care. Definitely, we as pedodontists should be aware, is aware of all this, but you are given it in a meticulous, minutest, step-by-step way, which will be easier for all those who are attending this course and this program. I congratulate you for that, Dr. Priyal. There are a few questions in the chat. I hope I can get one by one. Okay, that was the previous one.
Thank you, sir, for your kind words.
Yeah, thank you, Dr. Priya. Which fluoridated toothpaste is advised at 6 to 12 months?
So unfortunately, in India, most kids' toothpaste don't have enough fluoride in it. So for me, I have always prescribed the regular plain Colgate, either Colgate Strong Teeth or Colgate Total, or even a Sensodyne, because they contain a minimum of 1,000 to 1,450 ppm of fluoride, which varies over the batches. And I have done, multiple papers do suggest that as long as we can clean the toothpaste off the mouth oral cavity, they're absolutely safe to use. So I usually prescribe adult toothpastes. And the most common complaint of parents at this point would be that they find the toothpaste spicy. But the only way I explain it to them is that they have to use it like any other medicine. No medicine is going to taste good. So this is a medicine that they need to use twice a day. And over time, the child does get used to it. So for 6 to 12 months, there is no specific child toothpaste that has the appropriate amount of fluoride, but the regular adult toothpaste is good enough. Himalaya Oral Care is another, which has 998 ppm of fluoride, and it's not very spicy. So if the child is absolutely resisting, then you can suggest the Himalaya Total Oral Care.
Thank you, Dr. Priyal, for that answer. I hope a few questions were in that line. Pediflor 1,000, something like that. Anyway, that's That's
Pediflow
right.
1000 sir is one of the best toothpastes ideally, but it's very, very difficult to find. Its availability is very questionable. So they may find it the first time, but sustainability of use of that toothpaste is a big question mark. At least that's what I've faced in our demographics right now. So
Okay, fine, Dr. Priya. And I do find, I do want to sum it up, I mean, say that any cleft lip child is an high risk case, whether it has caries or not. So we should, from our point of view, consider it like a high risk case and give, as you rightly said, fluoride varnishes, the amount of this hypoplastic teeth is more, especially in the cleft. So it's better to give varnishes and that regular preventive care. That's what we are for. We do not disturb for. Yeah. I lost the track of questions. Ma'am, which is the link between cleft palate and the occurrence of enamel hypoplasia in nearby teeth? Is there a link between cleft palate? Yes, we do get a lot of papers on that. Any connections between the cleft palate and the occurrence of enamel hypoplasia?
yes,
A
yes,
teeth in
yes,
the
sir.
defect. Yeah, a teeth in the
Yes.
defect. That's all.
The defect itself is the cause of
Cause.
not appropriate mineralization or completion of the calcification of the tooth, because invariably the cleft does happen in vitro, typically when the primary teeth are being developed. So not only the primary, but even the permanent incisors are affected, because invariably the anterior teeth are going to be the subject during the surgical procedures. So even though the formation happens around post birth and not any time when the cleft is formed, the surgical procedure by itself can cause hypoplastic lesions in the permanent incisors. So that's a very important factor. As soon as you see a cleft, the patient must be kept on regular follow-ups for these anterior teeth that get locked in.
Yeah, that's the next. Thank you for that. A good compilation of cases for each stage of development of primary and mixed dentition. Thank you, Dr. Priya. And again, that comes from Dr. Lilita Jayaram. Thank you. Pediflow 1000, and now 1000 ppm toothpaste are available in market for children, Candy Cop and Pediflow 1000. If not, definitely it will be available in an app. I'm sure about it. If it's not available, they can get through apps, dental apps, or our Flipkart, and these kind of things can get this kind of toothpaste, but it's not regularly sold over the counter. But it should be, we should be one to advise the parents to use such kind of toothpaste to to these children. Dr. Mosumi, thank you. I'm just standing by for Dr. Pandit. Thank you, Dr. Mosumi. Thanks to the moderators for sparing time for this session. Good discussion. Yeah, thank you. Dr. Priyal, I have one question to you. How you ended up in this combination of this cleft lip center in Bangalore? What was your journey towards it? How did you? Because there will be many aspiring to help cleft lip children, but they don't know which center they should join. So can you give a guidance in that direction?
Sure. So I was just fortunate that correctly when I was setting out and starting, the cleft lip center required a pediatric dentist. So this is one of the first projects by SmileTrain and NGO where we have started providing pediatric dental care. It's basically a pilot program. We've just completed 5.5 years now, and we're hoping to now reach out to more centers once there is a more formalized protocol of how this works, because they realize the burden is so huge that for an NGO to be able to fund so many more centers, it's going to take a lot more standardization of care. And hopefully this will now spread its wings and we will have more and more pediatric dentists wanting to provide cleft care as well.
Exactly. It is a good exposure to them and good training they'll get. if they are at least work 2-3 months in a center. I think the part is there in the MBS curriculum to work in a cleft lip center. Great lecture, Dr. Shade. I don't think there is any more questions. So one more, I just want to sum it up again for those who are actively participating in this program. This is we should advertise ourselves of preventive dentists or pediatric dentists. Approach these centers. The centers may have a good plastic surgeon, good surgeon for all the other ENT and the whole team. What we have learned in our MDS days, the entire one chapter is on multi-specialty management of a cleft lip palate child. Of course, there is there. And my own personal experience, I want to put it as on a jovial note. 20 years back, there was a lecture by the Indian maxillofacial surgeon. The president of that happened to be a great cleft lip surgeon in my own hometown, Trichur. And the same Smile Train company is working in association with the Jubilee Medical Hospital in Trichur. So after the program, I talked to this senior surgeon who's even hold a Guinness record. Unfortunately, he passed away post-COVID. He's an old man, Dr. Edanwala. So he came from Maharashtra and settled in Kerala, Trichur. So yeah, so that's right, Dr. Edanwala. Yeah. So I asked him, sir, and he said, better come, you are asking so many questions. So which specialty you are? Or are you a maxillofacial surgeon? I said, no, sir, I'm a pediatric dentist. So he asked me, what is a pediatric dentist? I have heard dentistry, maxillofacial surgeon, then what is pediatric? I said, we take care of the child. Then he told, you are the person we are looking for taking care of the teeth. That's our role. We may not do, as Dr. Priyal, you rightly said, we may not be doing all that complicated surgeries, but the foundation of the teeth, that is in our hands. And we should expose ourselves to, that was just a personal, on a jolly note only. I was just joking. He is a president, national president of maxillofacial surgeon, and he doesn't know. Of course, he is a surgeon, not an maxillofacial surgeon. He's an MS surgeon. And he didn't know that there was a pediatric dentistry. Even now, that must be a lack of awareness of a subspecialty for pediatric children is there in dentistry. That must be even there in medical field. So we should expose ourselves, get into touch with such centers, and then, of course, we can do our service better to these children. As Dr. Priyal rightly said, the foundation is to have a good teeth. Then, because any cleft palate surgical procedure, if you know the foundation, how it is being done, naturally they keep the segments together to close the gap. And that leads to a malocclusion, constricted arch and class 3 type of developmental problem. And it is a burden to the parents. Multiple visits to the hospital and they will be running here and there for which place to go. So we can be as a guiding point to them now if we know the case. Thank you, Dr. Priyal, for this. I don't know, is there any other question? All are congratulating you for your good presentation. Dr. Jyotsana saying again a big thanks, great presentation. That question-wise, that is no. So I would like to conclude, and at the end point, I would like to thank ISPPD for calling me to moderate this wonderful session. It's a great privilege for me too. Thank you. Thank you from my side.
Thank you, sir. Can I have the certificate for sir?
Oh, sure. Sure, please.
Kindly accept the certificate, ma'am.
Thank you so much, sir. Thank you.
Can I have the certificate for the moderators?
Oh, we are also getting. Thank you. Thank you, Ran.
Thank you for your time, sir. Thank you for your time. And Indra Kumar, sir, Pandit, sir, because of the emergency, we need to go. And yes.
Fine.
So
Thank
that
you.
comes to the end of the sessions. Now I call upon Dr. Kunal Gupta to propose a vote of thanks.
Good evening, everyone. So, as a coordinator, it is my privilege to propose the vote of thanks for the successful completion of Module 1 of the Certificate Course in Special Healthcare Dentistry. At the outset, I would like to express a sincere gratitude to Dr. Maushmi Goswami for envisioning this course, which will go a long way in strengthening our ability to provide compassionate and competent care to patients with special healthcare needs. I would like to extend my heartfelt thanks to our President, Dr. Baliga, and Secretary General, Dr. Goel, and all other EC members of ISPPD for their guidance, encouragement, and unwavering support in bringing this academic initiative to life. A special word of appreciation to Dr. Anand Raj for organizing this module so efficiently. Your dedication and meticulous planning have ensured the smooth and successful conduct of this module. I extend my sincere thanks to all our esteemed speakers and moderators. Your valuable insights, expertise, and engaging discussions have truly enriched this learning session. I would like to definitely acknowledge all the participants for their enthusiasm and active involvement, which made this module vibrant, interactive, and meaningful. So as we conclude Module 1, I would like to leave you with a thought that the true measure of any healthcare system lies in how it treats its most vulnerable patients. So let us carry forward this journey, the knowledge which we have gained here, with empathy, responsibility, and a commitment to excellence. We look forward to continuing this enriching journey in the upcoming Module 2. Thank you all once again.
I'd like to note a special note of gratitude to ISPPD technical support, Dr. Mrs. Durga Pavani. Without our tremendous effort, dedication, and ability to manage the last-minute changes seamlessly, this online program would not have been possible. Thank you. You're amazing, Pavani. Nobody has seen her, but she is the.
Thanks, Dr. Anandraj. Thanks a lot for putting up such a wonderful show with actually no glitches, no nothing. It was really wonderful from your side. Thank you so much.
Thank you. Thank you. So we'll rise for a national anthem and next.
Yes.
Himachal Yamuna Ganga Uchala Jaladhikaranta Tava Shubha Name Jage Tava Shubha Ashish Mange Gaane Tava Jaya Gatha Jana Gana Mangala Dayaka Jaya He Bharat Bhagya Vidhata Jaya He Jaya He Jaya He Jaya 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 He.
Thank you all. So signing off.
Okay. See you all in Bangalore on 23rd of April. Bye-bye.